Vive una experiencia memorable en los Cobos Medical Center. Al norte de Bogotá se encuentra una institución de servicios de salud integral que se destaca por su modelo de atención centrado en el paciente y su familia. Los Cobos Medical Center cuenta con un equipo de profesionales multidisciplinario, altamente capacitados, que se encargan del tratamiento de los pacientes, el cuidado y mejoría de la enfermedad, bajo un modelo de atención humanizado, que responde a sus necesidades y a las de su familia. Tiene a disposición las unidades funcionales como son: servicio de urgencias, servicio de unidad de cuidado intensivo. Este servicio funciona bajo el concepto de UCI abierta, diseñado para que un miembro de la familia pueda acompañar al paciente las 24 horas del día, con el objetivo de favorecer su mejoría. Servicio de cirugía de alta complejidad. Las salas de cirugía cuentan con un sistema de telemedicina que permite la visualización de exámenes diagnósticos de apoyo y, en caso de requerirse, conexión con médicos externos. Además, permite la transmisión de la cirugía al auditorio y a las salas de educación. Servicio de hospitalización. Todas las habitaciones están diseñadas bajo las siguientes especificaciones: confort visual, gracias a una vista privilegiada de 180 grados hacia los paisajes de Bogotá y al jardín flotante exterior. Paneles integrados de atención para la seguridad del paciente. Diseño de ventilación y control acústico, lo cual genera un ambiente acogedor. Servicio ambulatorio. Consulta externa. Imágenes diagnósticas, entre las que están Adicionalmente, se cuenta con habitación para la prestación del servicio de medicina nuclear y procedimientos de radiología intervencionista. Los Cobos Medical Center cuenta con 6 programas especiales para la atención de pacientes cohortizados de Los Cobos Medical Center es una de las instituciones en salud más modernas de América Latina, con su diseño sostenible ambientalmente. Cuenta con amplios espacios, relajantes, con luz natural, diseñados especialmente para la comodidad y bienestar del paciente durante su estancia. En Los Cobos Medical Center, tú le perteneces a la vida, ya que es un centro de salud integral, donde el conocimiento médico, científico y académico se unen para que los pacientes vivan una experiencia memorable.
Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks. Ultomiris was built on the foundation of its predecessor, eculizumab, but has been modified to prolong its half-life. Both Ultomiris and eculizumab bind with high affinity to complement protein C5 in blood, thereby inhibiting its cleavage to C5a and C5b and preventing the generation of the terminal complement complex C5b9. One way in which Ultomiris and eculizumab differ is how they behave after binding to C5. Ultomiris is designed to release C5 in the endosome as pH levels drop, allowing it to bind with FcRn and be recycled back into the bloodstream where it can bind and neutralize additional C5. To further facilitate the recycling of Ultomiris, it has also been designed to bind to FcRn with greater affinity. The released C5 is then degraded by a lysosome. With eculizumab, binding to C5 inhibits FcRn-mediated recycling, leading to its lysosomal degradation along with C5. Through its modifications, Ultomiris has an approximately 4-fold longer half-life than eculizumab and provides immediate, complete, and sustained inhibition of C5. Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks.
Una experiencia de más de 67 años nos ha convertido en líderes en el mercado colombiano en la distribución de equipos y dispositivos médicos. Esto, sumado a un talento humano experto en el acompañamiento, distribución y mantenimiento, brindando soluciones oportunas y acertadas para la atención integral en salud. Pero, ¿qué hay detrás de esto? ¿Qué nos ha impulsado para seguir nuestro propósito corporativo? Aquí, más de 140 personas nos movemos al ritmo de las tendencias, buscando oportunidades, aportando nuestro conocimiento y experiencia por un mismo fin. Porque sabemos que no solo distribuimos equipos y dispositivos o brindamos un servicio de apoyo, porque sabemos que nuestro propósito impacta finalmente en la salud y bienestar de los pacientes, llevando esperanza de vida en los momentos que más lo necesitan. Porque nos apasiona trabajar unidos por un objetivo, porque somos expertos en lo que hacemos y porque innovamos para llevar a otro nivel el cuidado de la salud. En G-Barco, juntos, cuidamos la vida.
AVI sigue impactando la salud de los recién nacidos prematuros en el manejo del síndrome de dificultad respiratoria. Por más bebés en casa y menos en el hospital. Survanta es el surfactante seguro y eficaz para el tratamiento óptimo de bebés con síndrome de dificultad respiratoria del recién nacido prematuro. La Guía Colombiana de Práctica Clínica del Recién Nacido con Trastorno Respiratorio recomienda la aplicación de Survanta a dosis de 100 miligramos por kilo de peso. Survanta, dentro de sus múltiples beneficios, brinda mejor distribución de surfactante por su mayor volumen.
Surbanta cuenta con un sistema cerrado de administración que ofrece importantes beneficios para el bebé prematuro. Asegura una distribución uniforme en ambos bronquios, menor riesgo de episodios de desaturación y bradicardia. No es necesario desconectar el bebé del ventilador. Menor riesgo de infección. Precisión en el sitio anatómico de aplicación. Permite el reclutamiento óptimo y logra una administración más segura del surfactante. Surbanta se debe considerar como una excelente opción para el manejo del síndrome de dificultad respiratoria por respaldo en la Guía de Práctica Clínica Colombiana. Sistema cerrado de administración. Estudios de eficacia con experiencia de 29 años en el mercado. Soporte en recolección, disposición final de residuos y trazabilidad del producto. Respaldo de AVI en términos de farmacovigilancia. Por todos estos beneficios, Surbanta es el surfactante de mayor uso por los médicos en Colombia.
Live a memorable experience at Los Cobos Medical Center. In the north of Bogota, there is a comprehensive health services institution, which stands out for its care model, focused on patients and their families. The institution has a team of highly trained multidisciplinary professionals for the care of our patients, for the treatment and recovery of their illnesses, under a humanized care model that responds to their needs and those of their families. There are many functional units available, such as an emergency department, intensive care unit. This service works under an open ICU concept, designed in such a way that family members can accompany patients 24 hours a day, with the aim of promoting their improvement. High complexity surgeries. The surgery rooms have a telemedicine system that allows the viewing of supportive diagnostic exams and, if required, connection with external doctors. In addition, they allow transmissions to the auditorium and education rooms. Hospitalization. All rooms are designed under the following specifications. Visual comfort, thanks to a privileged 180-degree view towards the landscapes of Bogota and the exterior floating garden. Integrated care panels for patient safety. Ventilation and acoustic control design, which help generate a cozy environment. Ambulatory. External consultation and diagnostic images. Diagnostic images such as its facilities are habilitated for the provision of nuclear medicine services and interventional radiology procedures. Los Cobos Medical Center has 6 special programs for the care of cohortized patients of Los Cobos Medical Center is one of the most modern health institutions in Latin America, with its environmentally sustainable design. It has large relaxed spaces with natural light, specially designed for the comfort of the patient, aiming towards transmitting well-being during their stay. At Los Cobos Medical Center, you belong to life. In the care of a health center where medical, scientific, and academic knowledge come together so that patients live a memorable experience.
Vive una experiencia memorable en Los Cobos Medical Center. Al norte de Bogotá se encuentra una institución de servicios de salud integral que se destaca por su modelo de atención centrado en el paciente y su familia. Los Cobos Medical Center cuenta con un equipo de profesionales multidisciplinario, altamente capacitados, que se encargan del tratamiento de los pacientes, el cuidado y mejoría de la enfermedad, bajo un modelo de atención humanizado, que responde a sus necesidades y a las de su familia. Tiene a disposición las unidades funcionales como son: servicio de urgencias, servicio de unidad de cuidado intensivo. Este servicio funciona bajo el concepto de UCI abierta, diseñado para que un miembro de la familia pueda acompañar al paciente las 24 horas del día, con el objetivo de favorecer su mejoría. Servicio de cirugía de alta complejidad. Las salas de cirugía cuentan con un sistema de telemedicina que permite la visualización de exámenes diagnósticos de apoyo y, en caso de requerirse, conexión con médicos externos. Además, permiten la transmisión de la cirugía al auditorio y a las salas de educación. Servicio de hospitalización. Todas las habitaciones están diseñadas bajo las siguientes especificaciones: confort visual, gracias a una vista privilegiada de 180 grados hacia los paisajes de Bogotá y al jardín flotante exterior. Paneles integrados de atención para la seguridad del paciente. Diseño de ventilación y control acústico, lo cual genera un ambiente acogedor. Servicio ambulatorio. Consulta externa. Imágenes diagnósticas, entre las que están: adicionalmente, se cuenta con habitación para la prestación del servicio de medicina nuclear y procedimientos de radiología intervencionista. Los Cobos Medical Center cuenta con 6 programas especiales para la atención de pacientes cohortizados de Los Cobos Medical Center es una de las instituciones en salud más modernas de América Latina, con su diseño sostenible ambientalmente. Cuenta con amplios espacios, relajantes, con luz natural, diseñados especialmente para la comodidad y bienestar del paciente durante su estancia. En Los Cobos Medical Center, tú le perteneces a la vida, ya que es un centro de salud integral, donde el conocimiento médico, científico y académico se unen para que los pacientes vivan una experiencia memorable.
Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks. Ultomiris was built on the foundation of its predecessor, eculizumab, but has been modified to prolong its half-life. Both Ultomiris and eculizumab bind with high affinity to complement protein C5 in blood, thereby inhibiting its cleavage to C5a and C5b and preventing the generation of the terminal complement complex C5b9. One way in which Ultomiris and eculizumab differ is how they behave after binding to C5. Ultomiris is designed to release C5 in the endosome as pH levels drop, allowing it to bind with FcRn and be recycled back into the bloodstream where it can bind and neutralize additional C5. To further facilitate the recycling of Ultomiris, it has also been designed to bind to FcRn with greater affinity. The released C5 is then degraded by a lysosome. With eculizumab, binding to C5 inhibits FcRn-mediated recycling, leading to its lysosomal degradation along with C5. Through its modifications, Ultomiris has an approximately 4-fold longer half-life than eculizumab and provides immediate, complete, and sustained inhibition of C5. Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks.
Una experiencia de más de 67 años nos ha convertido en líderes en el mercado colombiano en la distribución de equipos y dispositivos médicos. Esto, sumado a un talento humano experto en el acompañamiento, distribución y mantenimiento, brindando soluciones oportunas y acertadas para la atención integral en salud. Pero, ¿qué hay detrás de esto? ¿Qué nos ha impulsado para seguir nuestro propósito corporativo? Aquí, más de 140 personas nos movemos al ritmo de las tendencias, buscando oportunidades, aportando nuestro conocimiento y experiencia por un mismo fin. Porque sabemos que no solo distribuimos equipos y dispositivos o brindamos un servicio de apoyo, porque sabemos que nuestro propósito impacta finalmente en la salud y bienestar de los pacientes, llevando esperanza de vida en los momentos que más lo necesitan. Porque nos apasiona trabajar unidos por un objetivo, porque somos expertos en lo que hacemos y porque innovamos para llevar a otro nivel el cuidado de la salud. En G-Barco, juntos, cuidamos la vida.
AVI sigue impactando la salud de los recién nacidos prematuros en el manejo del síndrome de dificultad respiratoria. Por más bebés en casa y menos en el hospital. Survanta es el surfactante seguro y eficaz para el tratamiento óptimo de bebés con síndrome de dificultad respiratoria del recién nacido prematuro. La Guía Colombiana de Práctica Clínica del Recién Nacido con Trastorno Respiratorio recomienda la aplicación de Survanta a dosis de 100 miligramos por kilo de peso. Survanta, dentro de sus múltiples beneficios, brinda mejor distribución de surfactante por su mayor volumen. Survanta cuenta con un sistema cerrado de administración que ofrece importantes beneficios para el bebé prematuro. Asegura una distribución uniforme en ambos bronquios. Menor riesgo de episodios de desaturación y bradicardia. No es necesario desconectar el bebé del ventilador. Menor riesgo de infección. Precisión en el sitio anatómico de aplicación. Permite el reclutamiento óptimo y logra una administración más segura del surfactante. Survanta se debe considerar como una excelente opción para el manejo del síndrome de dificultad respiratoria por respaldo en la Guía de Práctica Clínica Colombiana. Sistema cerrado de administración. Estudios de eficacia con experiencia de 29 años en el mercado. Soporte en recolección, disposición final de residuos y trazabilidad del producto. Respaldo de AVI en términos de farmacovigilancia. Por todos estos beneficios, Survanta es el surfactante de mayor uso por los médicos en Colombia.
Live a memorable experience at Los Cobos Medical Center. In the north of Bogota, there is a comprehensive health services institution, which stands out for its care model, focused on patients and their families. The institution has a team of highly trained multidisciplinary professionals for the care of our patients, for the treatment and recovery of their illnesses, under a humanized care model that responds to their needs and those of their families. There are many functional units available, such as an emergency department, intensive care unit. This service works under an open ICU concept, designed in such a way that family members can accompany patients 24 hours a day, with the aim of promoting their improvement. High complexity surgeries. The surgery rooms have a telemedicine system that allows the viewing of supportive diagnostic exams and, if required, connection with external doctors. In addition, they allow transmissions to the auditorium and education rooms. Hospitalization. All rooms are designed under the following specifications. Visual comfort, thanks to a privileged 180-degree view towards the landscapes of Bogota and the exterior floating garden. Integrated care panels for patient safety. Ventilation and...
Bueno, muy buenos días para todos nuevamente. Bienvenidos a este tercer y último Día de actividades del primer Congreso Internacional de Cuidado Intensivo de los Cobos Medical Center, Mayo Clinic, Universidad El Bosque, capítulo adultos. También saludamos a todas las personas que se conectan con nosotros a través de nuestro canal de YouTube vía streaming en la mañana de hoy, y queremos hacer una pequeña recapitulación de las actividades que tuvimos el día de ayer en nuestra segunda jornada, donde tuvimos actividades en nuestros grupos de interés en cuidado crítico de adultos y neonatal. Compartimos también con nuestros diferentes aliados en el auditorio central y les queremos recordar algunos de ellos que aún se encuentran en la mañana de hoy, como son Técnica Electromédica, Pfizer, Abbott, Lumex, Sanofi, Avi, Corpo Paul, AstraZeneca, entre otros. Así también damos entonces la bienvenida a nuestra primera conferencia de la mañana de hoy con el doctor Sunil Mankad, la cual se titula Fisiología y correlación clínica de la interacción cardiopulmonar. Antes de iniciar y darle la bienvenida al doctor que ya se encuentra aquí presente, queremos hacer una pequeña semblanza para que lo podamos conocer un poco más. El doctor Mankad es especialista en medicina interna, medicina crítica, medicina cardiovascular y ecocardiografía. Es también miembro del American College of Cardiology, del American College of Chest Physicians y la American Society of Echocardiography. Desde 2006 es también miembro del Departamento de Enfermedades Cardiovasculares en la Mayo Clinic, Rochester, y actualmente es profesor de medicina en la Mayo Clinic College of Medicine y es director de ecocardiografía transesofágica, así como vicepresidente de educación de la División de Ultrasonido Cardiovascular. Le damos entonces la bienvenida en la mañana de hoy al doctor Mankad. Muy buenos días.
Buenos dias, muchas gracias, dear colleagues. It is a great pleasure, and thank you so much to Dr. Luis Cortez and the entire organizing committee for this kind invitation. I have no disclosures, although I must say that I am not a true expert. Shown here in this important picture are the true experts in cardiopulmonary interactions. There is Dr. Cortez Puentes and Dr. Oakler. They are really the true masters of this field, but I will go over it from a critical care standpoint in more simplistic terms. Now, I did train at the University of Pittsburgh, and I had the great opportunity to learn from Dr. Michael Pinsky, and he did teach us quite a bit about how the interactions between the heart and the lung occur. I show you several publications here. I believe the PDFs of these talks will be made available. If not, please do contact me. I'm happy to send you a PDF of my presentation. But these are excellent review articles on the heart-lung interactions. So our objectives, and really this will cover in about 20 to 25 minutes, to cover the cardiopulmonary interactions in healthy subjects, in patients with respiratory disease, and then in cardiac disease, certain cardiac disease states such as heart failure. And importantly, the influence of mechanical ventilation in each situation. So the heart and lung are intimately related. They're in anatomic proximity within the thorax, and together they deliver oxygen to the tissue. In critical illness, failure may occur with the lung or the heart. And if either of these fail, oxygen delivery will be compromised. And if untreated, it could result in death. The restoration and maintenance of normal cardiopulmonary interaction and function is really essential. So one of the first, probably the first description of heart-lung interaction was by Dr. Adolf Kussmaul in 1873 when he described pulsus paradoxus. In his description, he talks of a 34-year-old female with restrictive tuberculous pericarditis. The patient was cachectic with edema of the legs and ascites. He notes her pulse would become smaller with inspiration, or it would become totally impalpable on deep inspiration. On expiration, it returned to its normal amplitude. The disappearance or diminution of pulse during inspiration was manifest in all palpable arteries. And we can see it either with stroke volume or with arterial pressure And this is the definition of pulsus paradoxus. Now, in normal physiology, what happens when we breathe, and shown here in this nice cartoon, when we take a deep breath, the venous return from the pulmonary veins into the left heart is diminished. The venous return to the right heart increases. As such, if you do TE, the pulmonary vein Doppler will be reduced. And the left side, the mitral valve peak Doppler inflow will be reduced. Whereas since increased flow occurred in the right heart, the tricuspid valve velocity will increase. And please note the septum shifts from the right to the left. And during expiration now, the opposite will occur. There'll be increased flow to the left heart. The septum will shift from the left towards the right, and the mitral inflow will increase, and the tricuspid inflow will decrease. So this interdependence occurs always. It becomes exaggerated in certain situations, such as constrictive pericarditis, but really, anytime you're on a ventilator, it may become exaggerated, and we'll explore that. Now, this interdependence can cause certain changes. Here, shown, for example, on the left-hand panel is a transmitral Doppler, mitral inflow. Shown below the Doppler is the respirometer. As the respirometer goes up, that's inspiration. As it goes down, it's expiration. And you can see during inspiration, the peak mitral inflow on the left goes down. And during expiration, the peak mitral inflow goes up. Now, hepatic veins, that's more sophisticated, but we can also look at, during expiration, diastolic expiratory flow reversal exaggeration as a sign of increased interventricular dependence, or in this case, constrictive pericarditis. Here's just a summary of the changes that occur in that description by Kussmaul in patients with constrictive pericarditis, where there's increased interventricular dependence. So the Doppler patterns of the heart are exaggerated. Now, one of the common things in critical care occur when we try to diagnose evidence of tamponade or constriction based on the transmitral Doppler. And shown in the upper left-hand curve are very similar transmitral Dopplers. And there's variation during the respiratory cycle. With inspiration, the peak mitral inflow goes down, and with expiration, the peak mitral inflow goes up. In the very top, up here, that's a patient with COPD. And just below it is a patient with constrictive pericarditis. They look very similar. In fact, the changes that you see in a patient on a ventilator or with COPD can be very similar to a patient with tamponade or constriction, looking at the transmitral Doppler. But what you need to do, and it's very simple to do by echo Doppler, is look at the superior vena cava Doppler, because they'll be very different. In a patient with constrictive pericarditis, the forward flow velocities will not vary. They will be the same during respiration. Whereas in a patient on a ventilator who's having changes in the transmitral Doppler due to just breathing and increased interdependence, the forward flow velocities will change. So in COPD and a ventilator, the SVC Dopplers will vary with respiration, but in constrictive pericarditis, they will not. The same in tamponade, they will not. So if you're concerned about diagnosing tamponade based on the transmitral Doppler by echo, all you need to do is look at the SVC Doppler, because it'll be very different in tamponade and constriction. All right, so the fundamentals of what we're going to talk about in the next few minutes are shown here. There is the thoracic cage and the pleural pressure that exerts itself on the RV and the LV. And those factors can affect venous return, and we'll talk about that. And then this concept of functionally afterload reducing the left ventricle occurs. So there's three things that you need to understand with increased cardiopulmonary interactions. One is, what is the effect that the interthoracic pressure has on the right heart filling? Okay. Second, what is the effect that it has on interventricular dependence? And third is, what is the effect that the transmural pressure or the pleural pressure, and we'll talk about what that means, is on the left ventricle and the right ventricle. So these three things will be explored in the next few minutes. The effect on filling, the interventricular dependence, and the transmural pressure effects. So let's first, though, take the transmural pressure. So ventricular filling is affected by the internal filling pressure and the external pressure around the heart. The pressure around the heart can be either positive or negative. If you're breathing passively and taking a deep breath, it'll be negative. But if you're on a positive pressure ventilation, of course, it'll be positive. The transmural pressure equals the internal pressure minus the external pressure. Generally speaking, during normal breathing, the external pleural pressure is -5 to -10, so it's a negative effect. This negative intrathoracic pressure increases venous return to the right heart and increases afterload on the left ventricle. The transmural pressure equals the systolic pressure minus the intrathoracic pressure. All right, so what is the effect? This happens in critical care all the time. I started my critical care fellowship in 1992, and I remember vividly when this paper was published. It's one of the first descriptions of what the effect that PEEP has on cardiac output, positive expiratory pressure. And what these authors found in a group of patients, a small study, but a group of patients with decompensated heart failure, they all had reduced EF, okay? But they all had a Swan-Ganz catheter, and we were able to see what their wedge pressure was. If your wedge pressure was high, and they defined that as greater than 12 millimeters of mercury, there was an increase in cardiac output. If your wedge pressure was below 12 in this study, there was a decrease in cardiac output. So all patients had heart failure with reduced ejection fraction, but if your wedge pressure was high, cardiac output went up. Similarly, in this same study, published the same year, and I remember vividly when this came out, we showed that in a group of patients admitted with decompensated heart failure, that prior group all had weak hearts. They weren't necessarily admitted with decompensated heart failure. These patients had decompensated heart failure. And if their pulmonary capillary wedge pressure was high, so you made the correct diagnosis, positive pressure increased cardiac output. Well, this is the same paper, I'm sorry. This one here is the group of patients with decompensated heart failure. If you gave them CPAP, their cardiac output went up. So the same thing is shown here twice, not the mechanism necessarily, but that if your filling pressures are up, and if you have heart failure, PEEP improved cardiac output. Now, why did that occur? Well, about 5 years later, Dr. Michael Pinsky in an animal model showed us that if you had a normal heart and your filling pressures were not increased and you had normal LV contractility, the effect that PEEP had was to reduce stroke volume. And he postulated that it was due to functionally afterload reducing the left ventricle in the cases of patients with heart failure, and the opposite in this case. So that the predominant effect in normal hearts is the effect that PEEP has on RV afterload and reducing LV preload. But if you had a failing heart, okay, a failing heart that was non-preload dependent, stroke volume actually went up. And you can see that the end systolic the line there, the elastance changed. So you did affect left ventricular function with PEEP. So stroke volume went up if you had a weak heart with heart failure and you added PEEP. Whereas if you had a normal heart with normal filling pressures, PEEP adversely affected cardiac output and stroke volume. So here's a diagram that I put together just to show that. So, in normal breathing on the left, and then someone on positive pressure ventilation on the right. And you can see that if you increase pleural pressure, you can actually then change the gradient between the LV and the aorta, because that positive pleural pressure will functionally afterload reduce the left ventricle. So this concept, keep it in mind, in the non-preload dependent LV, the LV that's failing, PEEP will functionally afterload reduce the LV. This effect will often predominate over the increase in RV afterload and will cause an increase in stroke volume. If, on the other hand, you had a preload dependent left ventricle, so in other words, normal filling pressure, whether your heart is good or bad, PEEP will generally reduce stroke volume and reduce cardiac output. Now, this is a paper just published last year, and I've often done it many times in clinical practice. Just turn the PEEP up and see what effect it has on stroke volume. Be very careful of just turning the PEEP up and seeing what happens to your blood pressure, because that could be variable, okay? But if you look at stroke volume, whether it be by Doppler or if you have a Swan-Ganz catheter, look at cardiac output, PEEP, turning it up, is a way to tell if your filling pressures are increased or not. And these authors looked at it in 64 patients, and they wanted to test, would you be fluid responsive in a group of patients who were admitted with respiratory failure. They were all mechanically ventilated and all had higher PEEP values. Now, turning PEEP down in people that need PEEP is not necessarily a safe thing, because you can't recapture the benefits of PEEP very quickly all the time. But in this study, they didn't have ARDS, and they reduced the PEEP. And if you reduce the PEEP and their cardiac index went up, they were volume responsive. If you reduce the PEEP and they had no effect, they were not volume responsive. So it's a maneuver you can do at the bedside in a ventilated patient to assess volume status, even if you don't have a central line. All right, so that's the effect on PEEP on the normal heart and those that are in the failing ventricle. And we'll summarize that again in a moment. But the other thing that we talked about, and this is exaggerated in patients on a ventilator, it's exaggerated in people with weak right hearts, such as those with pulmonary hypertension, and that is the shift of the septum that occurs. So when you have increased effects on the right ventricle, which PEEP will increase RV afterload, okay, that can affect what happens to the LV and reduce its compliance. So there is an interaction that always occurs, and turning up PEEP or increasing your ventilator volume, and we'll talk about that a little bit more, generally will increase RV afterload, but not always, as I'll show you. So here's a nice diagram just demonstrating that as you inspire, venous return to the right heart increases. As you expire, venous return goes down. So that's what occurs normally. And this is what we see in normal patients who are spontaneously breathing, this respiratory variation that occurs. And you can look at the arterial waveform or stroke volume and see that. Now, when you're on positive pressure ventilation, remember, the opposite of spontaneous ventilation will occur. Pleural pressure will go up. So when you cause increased ventilation, you'll increase RV afterload and reduce LV preload. And in the preload dependent ventricle, that will be adverse. So increasing ventilation and increasing PEEP will in general decrease venous return and increase RV afterload. But you got to be careful. And that was really shown nicely here by the three musketeers, Dr. Marini on the right, who I've been a big fan of and had the honor of meeting at Dr. Oakler and Dr. Cortez Puente's meeting. But they all have published this beautiful paper that's in the handout here. I guess it was 2018. They look a little younger. I would say they look pretty much the same, though. And Dr. Marini, who I've been a big fan of for many years, showed us that it's not that simple, all right? That, yeah, increasing, let's just say, volume of ventilation or increasing PEEP will, in general, cause flattening of these alveolar vessels that are affected by PEEP in red, okay? But as you increase the volume, that occurs, okay? Increasing the volume of ventilation. But there is a sweet spot, okay? And that sweet spot, you can increase the volume of ventilation and to a certain spot, and the functional residual capacity is what that is, that's when pulmonary vascular resistance is the lowest. So understand, you can increase PEEP and actually reduce pulmonary vascular resistance. Usually you go too far with the PEEP and it'll adversely affect pulmonary vascular resistance. But that's not always the case. You have to experiment and figure that out in an individual patient, because you don't know exactly where on that curve you are when you've either increased volume of ventilation or increased PEEP. So it's not that simple. And in the diagram on the right, and that's not from their paper, it's kind of hand-drawn actually by some authors at Mayo, but that resting functional residual capacity is the sweet spot. If you give too much lung volume, you flatten those alveolar vessels because the airway pressure of the PEEP or increased volume has flattened them, and you'll affect oxygen delivery. And too much volume will do that. Too low volume won't be good either. So you want to find that sweet spot. That's what I took home from their paper, and we can certainly ask them to comment. Now, just a couple of pearls. So positive pressure ventilation, the opposite of what we saw with spontaneous respiration will occur. You can see reverse pulsus paradoxus, so that with inspiration, stroke volume or blood pressure generally will go up. All right, blood pressure you really need to monitor with an art line if you're going to do that. Generally speaking, positive pressure ventilation will decrease venous return and increase PVR and RV impedance. But keep in mind, increasing PEEP to a degree may actually reduce pulmonary vascular resistance in some cases. Reduce LV preload will occur if you're a preload dependent left ventricle. But if you're a failing left ventricle, preload that's not preload dependent, it won't have that effect. And it'll functionally afterload reduce the LV and can improve things. So this is a nice diagram that just shows us cardiopulmonary economics. We want to optimize pulmonary SaO2 oxygenation, optimize cardiac output, and together then you'll have optimum or adequate oxygen delivery. So there's definitely an interaction. Now, a couple of other pearls that I've observed over the years, and I see this all the time. In a patient that you are needing to intubate because they're in respiratory failure, they suddenly then, after intubation, get hypotensive and are on multiple pressors. And the simple thing is, after you intubate, if they're hypovolemic, they'll get hypotensive. So before you intubate, make sure that a patient is relatively euvolemic, if you can, if you have time. But just know that the act of intubation itself and increasing lung volumes with ventilation can cause hypotension in the hypovolemic patient. And we see that all the time. It can occur in other settings as listed here, so you should be aware of those. But hypovolemia is the most common reason. If you overexpand the lung, you can create intrinsic PEEP from auto PEEP or auto PEEP, and that can increase PVR and affect cardiac output. So a little bit of PEEP may help right ventricle actually, but too much and too much lung volumes will make it worse. And it can cause pulsus paradoxus. It can cause bradycardia as well, and reflex arterial vasodilation in the inflation vasodilation reflex. So over ventilating isn't good either. So here's a summary of what we talked about of the cardiopulmonary interactions. Pleural pressure affects RV and LV preload and afterload. It is determined by the balance between alveolar units to collapse, elastic recoil, versus the thoracic wall to spring outwards. Generally, pleural pressure will influence RV inflow and LV outflow. And you need to keep in mind that it can be variable. So in an individual patient, it can change. Negative pleural pressure when they're intrinsically breathing will increase venous return and increase preload, decrease RV afterload when they take a deep breath, and increase our LV afterload in most cases. Positive pressure ventilation, which increases pleural pressure, will decrease RV and LV preload, increase RV afterload, in general and decrease LV afterload, especially in the non-preload dependent LV, and avoid large shifts which can affect LV afterload. PEEP affects RV and LV hemodynamics. It can be tricky. Total PEEP, of course, is the sum of extrinsic PEEP that we set on the ventilator and the intrinsic or auto PEEP. It's commonly used in the CICU all the time to benefit oxygenation. PEEP will help in patients in heart failure, but we've learned over the years PEEP will also help in patients with COPD. By keeping those airways open, a little bit of PEEP can help patients expire and get air out of the heart. PEEP will, in general, increase pulmonary vascular resistance, but remember, as shown by that paper by Dr. Oakler and Dr. Cortez, you want to find that sweet spot because initially it may be beneficial. PEEP generally decreases LV afterload in the non-preload dependent LV, but it can have variable effects on cardiac output depending on your filling pressure. It really is variable, so you got to individualize it a little bit and assess it. Airway pressure influences hemodynamics via its effect on the alveolar pressure and the pleural pressure. Airway pressure is determined by flow, resistance, tidal volume, compliance of the chest wall, lung parenchyma, and total end expiratory pressure. In other words, very complicated. Positive pressure ventilation exerts its effect through the cardiovascular hemodynamics, principally through its effect on the alveolar pressure and the pleural pressure. In poorly compliant lungs, changes in intrathoracic pressure will be more pronounced, the effects on hemodynamics. So here's a summary of what we talked about. Pleural pressure in spontaneous breathing patients goes down when they take a deep breath, and that generally increases venous return to the right heart, but it does slightly increase LV afterload. During positive pressure ventilation, there's increased transpulmonary pressure that will reduce RV preload, increase RV afterload in general, and increase PVR. But a little bit of PEEP may be actually beneficial. A little bit of increased volume may be beneficial in some cases. In the non-preload dependent failing left ventricle, those with increased filling pressure, the predominant effect will be LV afterload reduction. In the preload dependent left ventricle, you'll reduce cardiac output generally by increasing PEEP. So cardiopulmonary interaction depends on multiple factors. It's complicated. It differs with spontaneously breathing patients and those on a ventilator. You got to look at the status of the heart and lungs, whether they're normal or abnormal. And then other hemodynamic factors are important, such as the volume status and other medications that they're on. I didn't really speak of that. And I like this quote by Soren Kierkegaard: "To dare is to lose one's footing momentarily. Not to dare is to lose oneself." Thank you very much.
Bueno, muchísimas gracias al doctor Sunil Mankat por su intervención y continuamos con la actualización en falla respiratoria aguda con la intervención del doctor Bernardo Selim de Mayo Clinic, titulada Ventilación no invasiva cánula de alto flujo en el tratamiento de la falla respiratoria aguda. Conozcamos igualmente un poco más del doctor Selim. El doctor es profesor asociado de medicina en la Mayo Clinic College of Medicine y director de la unidad de cuidados respiratorios en la Mayo Clinic en Rochester. Después de completar su residencia en medicina interna en la Universidad de Boston, realizó su fellowship en medicina pulmonar, medicina crítica y medicina del sueño en la Universidad de Yale. Sus intereses de investigación y clínicos se centran en dispositivos avanzados de presión positiva en las vías respiratorias para tratar trastornos respiratorios relacionados con el sueño y la insuficiencia respiratoria debido a enfermedades neuromusculares. Damos así la bienvenida al doctor Bernardo Selim.
Muy buenos días a todos y muchas gracias por haber venido. quiero dar un gran agradecimiento a los Cobos y a la Universidad del Bosque por habernos invitado, a la parte organizativa, impecable organización, y nuevamente me gustaría extender este agradecimiento a todo el staff que nos ha mostrado un gran profesionalismo, pero ante todo una gran calidad humana, a recibirnos en la universidad, a la Clínica Mayo, el grupo de las Clínicas Mayo de acá. Así que muchísimas gracias por habernos recibido. Les voy a invitar que se pongan sus auriculares. Lamentablemente mi español cuando entro a la parte clínica no es tan bueno, así que voy a ir a hablar. Así que los invito a que se pongan sus auriculares y a la parte de traducción. All right, so here we go. We're going to be talking about acute respiratory failure, and we're going to talk about hypoxemic respiratory failure. So in a few minutes, you're going to be here about hypercapnic respiratory failure. It's going to be Dr. Lim. It's going to be a beautiful presentation. So I'm going to be focusing on the hypoxemic respiratory failure itself. So let's go to the next slide. So everything to me goes from the clinical perspective to explain through cases. And these cases, you have seen it all the time. This is a 45 male, unvaccinated, that happens to be having a COVID pneumonia. This patient presented to the emergency room with shortness of breath. This is, you have seen it all the time. Believe it or not, this is a patient that I have seen a month ago. So this is an unvaccinated patient. COVID is still out there. So you can see the vital signs. You can see the ABG, the PO2 70, and the FiO2 0.35. So you have a ratio, PO to FiO2 ratio, approximately about 200. Your total volume on the CPAP is somewhere between 7 and 8 cc's per kilogram of ideal body weight. So with respiratory failure, what are you dealing with? You are dealing with two different issues. One is the gas exchange, either hypoxemic respiratory failure or hypercapnic respiratory failure. And the second thing that you have to deal with is respiratory mechanics. And in the respiratory mechanics, this patient is in respiratory distress, and this patient has a compliance issue. So how are you going to have to decide it? You have to have a decision of something that is extremely important. Are you going to be intubating this patient, yes or no? And if you're going to intubate it, when? Not an easy one. Because if you intubated this patient and doesn't need to be intubated, this patient is going to have a high mortality. If you decided not to intubate it and you delay the intubation, you're going to have a high mortality. So you're dumb if you do it, you're dumb if you don't do it. So you need to be extremely selective how you're going to be supporting this patient. So what about if you decided to say, well, I'm going to be looking up into respiratory support that is non-invasive? You're going to be having two options. The options of going for positive airway pressure, or you're going to be having the options of high flow oxygen treatment, high flow oxygen nasal cannula. So when you're dealing with that, let's say that assuming that you're going to be doing this positive airway pressure, non-invasive ventilation, you're going to be deciding if either to give it CPAP or to give it bi-level. When you give it the CPAP or in your invasive mechanical ventilation through the non-invasive modes, you're going to be calling PEEP sometimes. What are you going to be doing? You're going to be increasing the mean airway pressures. That will be translated into a better oxygenation. The second thing that you're going to be doing is you're going to be increasing the compliance, and you're going to be preventing the de-recruitment. Now, if you wanted to unload the muscle load of these patients, what are you going to do? You're going to be adding to that PEEP, that pressure support. Now, how can you deliver that non-invasive ventilation? You can deliver by two interfaces. One is the oronasal interface that you see all the time. This is the one that you and us, we use all the time. Now, what about the other one, the one that you have there in this slide? This is the helmet. You don't use it here, guess what? We don't use it either at Mayo. We do have it only for research purposes. However, I bring it to your attention this type of interface because the majority of the data is coming from Europe. And if you have talked to Europeans, this is the interface that they use. So most of the data that we're going to review is on helmets. So, non-invasive ventilation in respiratory failure. So we have had, a few minutes ago, a beautiful review about cardiogenic components and how the positive airway pressure can influence that right ventricular preload that left ventricular afterload and make the non-invasive ventilation an excellent intervention, decompensating congestive heart failure, in these patients. So for patients with cardiogenic or pulmonary edema, no problems. What happens with patients who have COPD? Non-invasive ventilation by levels, fantastic to prevent intubation. So this is one of the first line. There's a lot of literature supporting, very robust. So no discussions with that. What happens with obesity? Also non-invasive ventilation with bilevels. But the problems comes when you're talking about hypoxemic respiratory failure. And into hypoxemic respiratory failure, this is when it becomes tricky. What hypoxemic respiratory failure into the ARDS will be convenient for treatment with positive airway pressures. So this is data that has been accumulated through times, particularly during the pre and post ARDS COVID. And you can understand there that patients who have mild ARDS, these are PO2, FiO2 ratios, somewhere in between the less than 300 to 200. These patients, reintubations or failure to non-invasive ventilation is around 22%. What happens with the other ones? The ones with the ARDS that is moderate to severe. In these patients, you can see that their failure to non-invasive ventilation that translate into intubation, it's around 42%. So it's pretty interesting. So for you to compare, when we have COPDers and we place them in non-invasive ventilation, the ratio or the failure rate is around 15 to 20%. I repeat, the failure of intubation, 15 to 20%. When we go to ARDS, in the moderate to severe, 40 to 47%. So what is the physiology parameters that will tell you if the NIV will fail? Is there anything that you can know in advance? So this is a physiology study. This is a beautiful comparison of ARDS patients that around 15 subjects that they have been comparing between high flow nasal cannula and non-invasive ventilation. And in this one, again, the delivery system of Intervase has been a cascade. So they have been looking through a balloon, esophageal balloon, the respiratory efforts, and they have been measured different parameters. So in these patients, in the first graphic that you have on your left, you're going to be seeing that in this axis, you have PO2 to FiO2 ratio, and the three interventions that they did in these patients: low oxygen flow, high oxygen flow, and also the non-invasive ventilation through a helmet delivery. And you can see that the oxygenation in these patients, and I'm going to try to see if my there you go. You're going to see that the patient with high flow system versus the patient with non-invasive ventilation, the PO2 to FiO2, the oxygenation component is much higher. What happened with the patient with a respiratory or a respiration rate? The respiration rate falls in comparison to the high flow nasal cannula. So what else does the non-invasive ventilation in comparison to the high flow does? It will lower the inspiratory effort, and it's also going to reduce the respiratory load. So all this intervention happens in these patients when you place them in non-invasive ventilation. All right? I want you to stop here for a second, because I need you to pay attention, particularly something that you do know, but I wanted to make it extremely clear, is that you have to be concerned about your intervention with non-invasive ventilation. This is the NIV limitations in ARDs. This is the PCILI. This is the patient self-injury of the lung. And what is happening? So you have on one extreme of the slide, a patient that is intubated, paralyzed, that has been placed in pressure control. You can see here, and I'm going to try to do here, this is your pressure control, and this is your transesophageal pressures. So the difference of pressure, the transpulmonary pressures, is minimal to none. So no problems, this is protected ventilation. But when the patient is being extubated or never been intubated, and you put it on pressure control, the component that you and me, we don't know, either in the emergency room or in the ICU, is what is happening with the esophageal pressures. Because these patients can be generating an extreme large intrathoracic pressures, which is going to making this delta pressure extremely large. That's going to be that transpulmonary pressure that they will be tearing apart their own lungs. So predictors of failure for non-invasive ventilation. And this is some of the scores that currently we are using. And I will be very interested to know if you're using these scores too. This is the hardcore score that is taking into account the heart rate, the acidosis, the consciousness, the oxygenation, and the respiration rate. And when they take this score in this study of ARDS of 500 patients, they were able to recognize that these could be good predictors of patients who fail to non-invasive ventilation. So if you do a hardcore score into the first hour, I repeat, into the first hour, if this hardcore is 5 or above that, you have 85% of prediction of failure to non-invasive ventilation. So you better intubate these patients, because if you intubate these patients early, you can prevent mortality in these patients. So it has to be very clear, the hardcore score can be a very useful clinical tool into the first hour of non-invasive ventilation. So we come back again into this patient. And in these patients, the vital signs, you have your vital signs with the heart rate, respiration rate, pH. And then these patients, you can classify that it has mild to moderate ARDS, a hardcore of 3 points, and you have a total volume of less than 9 cc's per kilogram. So if you have fallen asleep because of my talk, that's fine. You can wake up right now. You can take a picture of this slide, because I do believe that this is just sum up the ideas about respiratory failure in these patients. So you do have the patient component, that is the PO2 FiO2 ratio for your pre-selection of patients that may fail or not to the non-invasive ventilation intervention. So if you have these patients with moderate to severe, do not try non-invasive ventilation. If the patient has multiple comorbidities, or is very sick by the Apache score, try to avoid non-invasive ventilation. What happens with the response of the patient to the non-invasive ventilation? If this patient has an increasing inspiratory effort, increasing respiration rate, or this patient has tidal volumes that they are 9 liters or more than that, or 9 cc's per kilogram or more than that, that's going to be patients that they're going to fail to non-invasive ventilation. All right, so I think that we're going to go to next slide. There you go, thank you. So let's say that you change your mind and say, no, non-invasive ventilation is not that good for my patient. What about if I give high-flow nasal cannula? We have done it. This has been a very, very rampage knowledge that we have to have because of ARDS. And all of our ARDS patients were at some point in high-flow nasal cannula. So what we do, we increase the inspiratory flow of these patients. So this shortness of breath, this gasping is starting to be improving this patient, decreasing the respiration rate. We wash out that CO2 and we increase the end expiratory volumes. But what we're doing with the PEEP that we can generate from the oral pharyngeal is not very important, but it's approximately 1 to 1 when you do in 1 liter of flow. So that you can generate approximately 5 to 6 centimeters of water of pressure, which cannot be very important into that. So, oh, sorry about that. Okay, so what can predict the failure of high-flow nasocannulary hypoxemic respiratory failure? And in these patients, I may be having problems to advance the slide. There you go, thank you. We may need to do it manually, thank you. So the predictors of failures of high-flow nasocannula, there you go, thank you. It's the Ross index, that is the oxygenation for the respiration rate. And this is something that we have incorporated into our medical records, and you can incorporate it to your records too. This is very simple calculation of your PO2 FiO2 over the respiration rate. And you do have 2 hours, 6 hours, and 12 hours that you're measuring. And as you can see, I don't remember the 4.88, I remember the number 5. And if the number 5 is above that, then you have a positive predictive value of approximately 80% or more that this patient will succeed to be continuing high-flow nasocannula. What about if there is less than that? Then you have to be worried that this patient will be failing non-invasive ventilation. Next one, please. Thank you. So can I avoid intubation and improve mortality in ARDS or NIV? This is going to be our next slide. And in the next slide, we're going to see, thank you. We're going to see this study in which is going to show us a systematic review and a meta-analysis, 25 randomized clinical trials that we have trialed And these patients with ARDS, we have seen into low flow, high flow, and non-invasive ventilation. This is a plot analysis that tells you the circular part is about the intervention, and the lines in between them is the interrelation, and the thickness of the line represent the number of studies that they are in between them. If we go to the next slide, we're going to see that in bottom line, where we're looking up into is prevention of intubation and also mortality. Next one, please. And we're going to see that the survival 90 days. The non-invasive ventilation has a survival signal there, not the high flow nasal cannula. But if we go to the next slide, we're going to have the summary that endotracheal intubation at 30 days, both intervention, non-invasive ventilation and high flow, can decrease the mortality, the reintubation at 90 days. So what we're trying to say is that if you wanted to change mortality, non-invasive ventilation has been a clear signal. If we wanted to prevent intubation as an outcome, then both interventions are being effective. Next one, please. So what happens with the most recent review of meta-analysis? It tells you exactly that the mortality and reintubation for non-invasive ventilation, the high flow nasal cannula is for prevention of reintubation. Next one, please. So what the guidelines tells us? The guidelines tells us, next one, that for example, the European Society of Critical Care Medicine is telling us that the patients in between CPAP and NIV in comparison to low oxygenation, the CPAP over conventional oxygen therapy is recommended. Next one, please. And what happens with the European Respiratory Society is telling us that if you have a hypoxemic respiratory failure, start with the high flow nasal cannula. The non-invasive ventilation is not recommended. There's no clear guidelines for that. Next one, please. Oh, no, if you want to go back to, sorry about that. High flow nasocannula non-invasive ventilation is just for the post-op patients at high risk. And also they say, well, non-invasive ventilation over high flow when you have a patient that you extubation and your extubation goes into failure. So these are the three scenarios that you're going to be thinking about non-invasive ventilation. Next one, please. I think that I will finish here. I think that I have my 30 minutes. Otherwise, I'll have more than happy to extend into the next 3 slides. Are we on time? On time? Perfect, fantastic. Okay, I'll leave it here. Thank you.
Bueno, tuvimos al doctor Bernardo Selim con la actualización en falla respiratoria aguda con la intervención del doctor en ventilación no invasiva y cánula de alto flujo. Continuamos en este momento con el doctor Richard Ockler, que cierra esta primera parte del abordaje integral de la falla respiratoria aguda con la conferencia Protección pulmonar y potencia mecánica. El doctor, conozcamos igualmente un poco más del doctor Richard. Él es director de la Unidad de Cuidados Intensivos Médicos y director médico del programa de rehabilitación de la Unidad de Cuidado Intensivo de Mayo Clinic. Es profesor asistente de Medicina y Fisiología y consultor en la División de Medicina Pulmonar y Cuidados Críticos en Mayo Clinic en Rochester. Recibió también el prestigioso premio Parker B. Francis de investigación pulmonar y continúa realizando investigaciones clínicas y translacionales en ventilación mecánica avanzada, prevención y tratamiento y manejo de la hipoxemia refractaria. Démosle la bienvenida al doctor Richard Ockler.
Spice it up a little bit. Buenos días. Lo siento, pero solamente hablo un poquito español. I'd really like to thank the organizing committee and folks for inviting us, and I think I can speak for all of us from the Mayo Clinic that we're very impressed with all of you, as well as the wonderful facility that you have. This is really a beautiful state-of-the-art facility here, and really a testament to your dedication to patient care. So I'm going to talk a little bit about what happens when you ignore Dr. Bernardo Selim's advice and let someone wallow away on non-invasive ventilation for a little bit of time. Then somebody calls a rapid response team and I wind up with that patient in the medical ICU, or you all wind up with that patient in your ICU. So I have no disclosures. I'll just briefly cover the learning objectives. I'll talk a lot about first do no harm. I'll explain that in a second. I think the take home from this, we'll get all the way through mechanical power to discuss that, but I want to talk about several different strategies for preventing ventilator-induced lung injury and acute lung injury. And I think one of the take homes is going to be that in 2024, I think for most of your patients, limiting your driving pressure alone will be adequate, but we'll explore that concept of this evolving idea of mechanical power and its limitations and benefits as of today. So what are the general goals of mechanical ventilation? Well, I highlight there multiple times the word safe. So we want to provide gas exchange to match demand. We want to do it so the patient is comfortable, and that can look like patient ventilator synchrony. We want to do it safely, also synchrony, but also not causing harm to the lung. And we want to continually reassess to remove the tube. And here you can see one of our respiratory therapists actually playing his ukulele to the patient to try and keep them calm to extubation. As we've had some discussions so far during this conference, I think you know that I like to talk about when and when not we should follow the rules. I also like to philosophize and talk about the art as well as the science of mechanical ventilation and critical care in general. And this is one thing I really want to emphasize. You'll see multiple studies comparing one mode to another mode and say pressure control is better for a patient or volume control may provide a mortality benefit. And I would ask you to just think about the fact that the ventilator is not a therapeutic device. When I come up to this patient and I'm going to adjust the ventilator, I'm just supporting this patient as best I can while we treat the actual underlying cause of the respiratory failure. And so, at least in my view, I don't understand why we expect the ventilator per se to improve the patient's outcome. In fact, if I do my job to the best of my ability, probably the most will be that I will unchange or there will be no change to the patient's condition just based upon the mechanical ventilation, which is actually ideal while we address, again, that underlying pathology. So I would argue that you have one job, and it's to not weaponize that ventilator whenever you get up there to cause harm. So let's talk about what the risk of not doing your job is. It's really, there are a number of different terms. You've heard about barotrauma, adalect trauma, volume trauma, lots of different terms for the changes that are going on both on the macro level and down at the cellular level, where you can see in this slide a number of the different cellular changes that occur and can lead to then a cascade of multiple inflammatory markers that really can affect end organ damage and the mortality in general. And so it's always important, we talk a lot about this airspace interface between the vascular compartment and the airspace compartment. And we'll talk about that a little bit as we move on. What's my problem though? No matter what ventilator you have, no matter how fancy it is, I come to the bedside, what number or value on this ventilator screen is telling me that the lung is safe? We really don't have a good way of doing that on any of the common ventilators to know what's going on at that airspace vascular interface. So what do? We use surrogate markers. And so that's the question. They're easier to calculate a number, but are they adequate in this day and age? So we'll talk a little bit about how we've moved through tidal volume to plateau pressures, driving pressure, and then maybe mechanical power. So this is just a picture of me. I've become old and fat. I used to be a pretty good skier. Now I just ski in my backyard there in Minnesota. But I show this slide because I would like to use kind of the skiing model of rating of trails. So easier, the green circle, intermediate, the blue square, and the diamond is kind of the more advanced techniques. And so you're all familiar with tidal volume and plateau pressure and why we limit those. I won't spend a lot of time on that, but we'll just briefly go over the data that's kind of historical and has driven us up through the driving pressure and the mechanical power issues. Advanced mechanical ventilation can be an entire course on itself. Dr. Mankad provided a beautiful overview of cardiopulmonary interactions, mechanics measurements, whether that's esophageal balloon, EIT, some of the other more advanced techniques, and then really looking at that occult effort in asynchrony. And we did speak a little bit with the trainees yesterday about what I would call off-piste or off-trail skiing, or in this case, off the guidelines, where the guidelines don't apply, and you really have to then lean on your applied physiology and knowledge to do the best that you can. If you know your physiology and you know how to apply it, this is advanced mechanical ventilation. But to those who don't understand that physiology, it's more this occult magic or witchcraft to say what's going on there. So tidal volume and plateau, I don't want to spend a lot of time on this, but I'll just quickly move through. You all know that on the left, you can see the relationship between tidal volume and ideal body weight. It tracks very well, predicting the size of a normal lung, but not at all when we look at a lung that could be a diseased lung or ARDS, where we deliver a set 6 cc's per kg, but utilizing a ventilator that we were able to measure actual lung volume, that set 6 cc's per kg actually turned out to be anywhere between 8 to 14 in these patients we ventilated back in 2011. You all know the data again on ARDSNet, and so I won't belabor that as well. It is interesting to notice from the old ARDSNet data that really drove home the point of limiting tidal volume to improve outcomes, that the patients with the best lung compliance really didn't have much of a benefit of tidal volume limitation. And that may be relevant as we start to talk about driving pressure and when it can be beneficial and when it may not be. On the right, you see the lung safe data, which suggests that maybe there is no actual plateau pressure threshold, and that maybe just the lower, the better. So, and that's looking at mortality. So what are the pearls of this? And again, you all know this, but it's non-invasive, it's quick, it's easy. We can just actuarially set these numbers. We can read a plateau very easily on most modern ventilators. And most of our historical data is based on these types of numbers. And so there's a lot of literature to support it. And certainly, and this is a key point, limiting your tidal volume will prevent overdistension or barotrauma, but potentially lead to more atelect trauma as you have more of that open and collapse injury at the end of expiration. So where are some of the pitfalls? Well, it's not individualized, as we just talked about, to your lung mechanics or your pathology. There are dead space issues, certainly, as you drive that tidal volume down further and further, especially in a diseased lung with high dead space, that you're going to wind up with issues with hypoventilation, potentially significant issues with hypercapnia. And then, of course, these patients already are air hungered, and so they have a high PMUS or a high respiratory drive. And so if you try and limit tidal volume on those patients, they will, as Dr. Salim and Dr. Mankad were talking about transpulmonary pressure, they will have a high PMUS and a high risk for lung injury. Like my mentor used to always like to say, Dr. Rolf Hubmeier, he would say, the brain will sacrifice the lung to save itself. And so will just cause you to breathe heavier and heavier, trying again to improve its oxygenation. So, you know, on a satisfaction survey, how satisfied are you with using tidal volume and plateau in 2024? It's fine. I think you'll be okay, but I think we can do better. And so you all are, of course, familiar with driving pressure. That's become, I would argue, at least in our ICUs, the kind of the standard target nowadays. And so what's the rationale of driving pressure for those of you who are just starting to learn this? Well, instead, again, of scaling your tidal volume to your ideal body weight and the predicted size of the lung, we want to scale the tidal volume to the actual lung compliance we're seeing at the bedside now. And so, you know, for any given breath, at least on volume control, what would your change in volume be? Change in volume for change in pressure is going to be your compliance. Change in volume will be your tidal volume. Your change in pressure will be your P-plat minus your PEEP. And so, of course, again, we're not going to scale till tidal volume. We'll scale our tidal volume to the lung compliance. And so those parameters cancel out. And that's how the logic of how we get to driving pressure being P-plat minus PEEP. You all are probably familiar. This is the famous Amato study on the left, showing that there's a threshold probably around 15 centimeters of water where mortality starts to increase. When that driving pressure goes up and up, mortality, of course, is increasing. It also does not look like there may be a specific threshold. And again, from lung safe, it does look like just the lower the driving pressure, the better, as mortality improves as driving pressure moves down and down. And that probably makes sense. Again, at least until we get to the point where we have lung collapse and adduct trauma, or that open and close injury. So the pearls of driving pressure, it's again non-invasive, so we don't have to have a lot of special tools or techniques to calculate your driving pressure. A key thing here is now we're starting to talk a little bit about the equation of motion, and so we're starting to incorporate the elastic components of the respiratory system. Again, we'll tease this out a little bit more with mechanical power, but at least we're starting to get more of an integrative readout of total breath cycle stress. So we're kind of integrating tidal volume, plateau, compliance. And again, I would argue it's good enough for the majority of your patients, and we'll talk about why in a minute. Pitfalls, again, you're still beholden to P-plat, right? And P-plat can be influenced by what? Your chest wall stiffness. Now, your folks walking around Bogota, they seem like they're in much better shape than they are in our Midwest svelte, large, Botero-type patients. And so we have a significant chest wall stiffness and compliance issues in our ICUs. A BMI of 80 is not uncommon in our ICU, and sometimes in excess of 100, we can see a BMI. And so we have significant challenges sometimes with ventilating these patients. And so driving pressure can be challenging in those situations. We'll talk a little bit more about that in the next talk with refractory hypoxemia. Again, so we're not looking at the full dynamic component here. We are integrating one breath and its cycle stress, but we're not really looking at frequency or some of the other factors that we know can lead to VILI. And so we're still not integrating all of those components that in 2024 we know can cause injury. And so again, the limitation seems to have a benefit on mortality, and in most patients will be good enough, but I think we can do better with mechanical power. And so the special patient cases here I have at the last part of the slide are those we were just talking about with the altered chest wall compliance. Again, we'll talk about that in refractory hypoxemia. And this is specifically the case I'd like you to think about for my next talk is, can there be a time where driving pressure limitation could be harmful? I just show you data both from LungSafe, the Amato study, there's the Serpinieto study, there are Villar study, there are all sorts of studies showing benefit of driving down that driving pressure as far as you can go. But there may be sometimes that is not the case, especially with a very stiff lung that you can't ventilate and they're very hypoxic and hypercapnic. So driving pressure in 2024, I'd say it's somewhere in the good range. I think for most patients, probably it's, again, acceptable. So let's move on to really the crux here, which is mechanical power. And I do hear that you're using it a little bit here, so hopefully this concept isn't completely new to you. But what is it? Why is it important? Again, we're trying to capture total breath cycle stress and strain, and then look at the fact of that's happening over time. So we're not really interested when we're talking about injury in one breath cycle. Certainly if I give an extra large tidal volume, I can cause barotrauma and a pneumothorax. But most of the injury we're concerned about is happening over time. And so we really want to integrate not only the impact of that one breath cycle, but then the fact of that being almost jackhammered or pounded into the lung each time, delivering that total mechanical energy transfer. And this is considered to be the unifying driver of VILI. Here I just have a schematic. I'll point out for the sake of discussion because you'll hear me use these terms a bit. On the right, you see the total energy in a breath cycle. This is a pressure time tracing. But what we call this is certainly I'm sorry about the flow resistive component here. Then we have the tidal elastic component here, and then the component of PEEP or static static energy delivery. And so together, that's the total energy you see on the right there. Same slide, it's a little busy. Provide the references and the QR codes there. Again, I think you're getting the point that the nice thing here, and the formulas on the bottom, the complex formula from the initial Gatnoni paper in 2016, of the mechanical power, incorporating all of the elements of the equation of motion. I spell them out in the bullet points there, all of the things that we're integrating. Again, the key thing here is looking at all of the components that we really, at this point in this day and age, understand can influence ventilator-induced lung injury. The good thing for us is that this equation at the bottom here, it looks quite complex. And so there are simplified equations that now have been validated and are a bit easier to use at the bedside. And so again, provide the references there. You see on volume control, the reference in bold there is the equation that you would use. And for pressure control, it's a little bit different, but they're simplified and makes it a little bit easier to calculate and a little bit more easy to implement at the bedside. I don't want to spend a lot of time on this, but all of the components probably do not contribute equally, although there's some nice newer data from Dr. Colino that suggests that maybe the PEEP data, let's just say it would depend. There may be a threshold of PEEP where that it's important and may contribute more than in normal levels of PEEP. So this is this paper here, and what she showed, and this is in animal models. So these are pigs looking at different set points of PEEP, and when we're down in the, when we're at the lower range of PEEP and we increase the PEEP, the dotted area here is the driving pressure related contribution to the mechanical power. And so you can see as we increase PEEP, when we're at a low PEEP level and we're improving the respiratory mechanics, stabilizing those recruited units, the overall mechanical power, despite the increase in PEEP in the darker gray areas here, does not change. And the driving pressure related component to the mechanical power is actually going down. However, we do reach some threshold here, but somewhere between 7 and maybe 11, where the mechanical power now starts to go up because we've exceeded probably where we need to be on the PEEP. We start to over-distend the lung, and it takes more mechanical power to deliver the same ventilation. That also is seen in the bottom charts here when measuring different markers of lung injury. So whether it's congestion, inflammation, alveolar collapse, et cetera, et cetera. And so we start to see that there may be a threshold PEEP level that will affect the overall mechanical power. Sometimes the PEEP may actually help you reduce mechanical power or at least improve your ventilation, sometimes not. So this is a study from piglets from the same group, looking again at what are the thresholds of mechanical power that we should be targeting. And why you'll hear me say at the end here that maybe mechanical power is ready for prime time, maybe it's not, is that you notice a lot of the studies are in animals. The ones that are in humans are smaller studies, and I think there's still a little bit of debate on the threshold, but let's talk about that. So in these piglet studies, on the left is a graph of the injury, and you can see the matching radiographs, and this study basically just looked at different radiographic evidence of injury as these piglets were ventilated at either a higher tidal volume on the left and a lower respiratory rate, or on the right, a higher respiratory rate and an average tidal volume. So trying to tease out which component of mechanical power may contribute more to injury. And as you can see, they come up with a threshold here where it looks like there's a big jump in lung injury at about 11, 12 joules per minute. And it's independent of whether it's rate or volume that's contributing to the mechanical power. These are data from humans in non-COVID-19 patients, so pre-pandemic. This paper started to look at trying again to decipher a rote threshold. And so the threshold was somewhere around 17 joules per minute, and a pretty good size study. You see that the N is 8,200, and that was patients that were ventilated for more than 48 hours. COVID-19 patients, interestingly, because of the prior study, they used the 17 joules as a cut point, analyzing patients that were ventilated at less than 17 joules and higher than 17 joules. And so you can see there does seem to be a survival benefit for that limitation. The question is, though, is just a rote threshold important, or should we be looking somewhat like we're scaling tidal volume to ideal body weight, or in the driving pressure category? Maybe we should look at mechanical power delivered to the size of that baby lung and normalize it to that. And so there were a couple of studies on that. I'm just going to skip through here, looking at a normalized ratio. So we used that original equation, and that would be kind of our MP expected. You see at the denominator in this ratio. So the expected mechanical power, and we divide the actual mechanical power we're measuring at bedside, and then use that number as a guide. And it appears that about 4 times the predicted mechanical power results in injury, at least in this group, again, of patients. So the issue is, again, most of this data is also coming from either pigs, piglets, and very small human studies. But it's interesting because it does start to create, again, a scaling to that baby lung, and why we're also interested in improving the baby lung and the mechanics of the baby lung with things like prone positioning. Again, we'll talk about that a little bit later this morning in the refractory hypoxemia talk. So I think the other key is, and what complicates this is, you have a mechanical power threshold, but that threshold may also be determined or colored by the actual context of the lung. So injury and inflammation that's present may actually lead those membranes to be more susceptible to the mechanical power or the ventilation strategy and cause villi. And so these are the complex interactions that we're still trying to tease out. Let's say in this day and age, to 2024, we may choose to limit our mechanical power if we're using it to 17, but that may, as we get more and more evidence, that may be dependent upon, again, the situation, maybe based with inflammatory markers, et cetera, et cetera. But just something to be aware of, that amplifiers of stress, heterogeneity of the lung, and then all of these different inflammatory cascades can certainly lead to more injury. And it's why we're so adamant when we come to the bedside and we do some of these maneuvers that we try to homogenize the lung, take away those stress concentrations as best we can that Jerry Mead described back in the 1960s and 70s, and to really minimize the underlying milieu's susceptibility to lung injury. This is out of the Toronto group with Laurent Burchard and others, looking at maybe simplifying mechanical power further, potentially just multiplying the respiratory rate by the driving pressure. And it's a little bit interesting because what I really take home from this is that when you have a better lung compliance, so on the left graph here is the risk of mortality based upon the solid line being driving pressure and the dotted line being respiratory rate. And what it tells me is that when you have a better lung compliance and a lower driving pressure, and this seems to be commonsensical to you, I'm sure as well, is you probably, if you're still hypoxemic, hypercapnic, you probably should increase the tidal volume. Whereas if I'm already in a stiff lung, here in the top curve, and I would be to the right of this transition point of about a driving pressure of 15 and a respiratory rate around 25, then I really need to decrease the tidal volume up here, as you can see, the respiratory, and increase the respiratory rate in compensation. So again, it's a small study. It's looking to maybe simplify mechanical power even further, to distill it to just the elements that are most applicable in most situations. More data to come here, but it does suggest that maybe based upon the lung compliance, the mechanical power and the adjustments that we make and our targets may differ. And that really would make sense. Just one slide on weaning as I finish up here. Also looking at the odds of weaning, you could use this as a screening tool or a target if you're trying to wean patients, and you can see that around 10 joules per minute or 0.15 joules per minute per kilogram, ideal body weight, there seems to be a pretty good sensitivity and specificity or area under the curve here. And so, again, it may be a target moving forward, but we just need a little bit more data. So the executive summary on mechanical power, it's dynamic and holistic. I think at this point, it's the most complete estimate we have of not only breath cycle stress and strain, but the implications of the cyclical stress element over time based upon the respiratory rate. The issue is the thresholds remain murky. And so lower is better, but we don't know if there's a really solid cut point. That being said, 17 nowadays looks like it probably is at least safer than above 17, but you could probably argue on some of the newer data that's in press that there's not going to be a threshold, and again, the lower the better. The pitfalls, it's more complicated. You have to have a complicated equation at the bedside. The ventilators don't just read out mechanical power. Some EMRs do. Our EMR at Mayo, we've actually have developed so that we read mechanical power into our EMR. But again, it's not something that you're getting a real-time readout at the bedside on. And so, you know, I'd say the verdict is still out. Mechanical power is definitely the future. I'm not sure it's completely ready for prime time, but certainly if you're using it, target the lower the better. And think about that last study I showed with Burchard and maybe adjusting this based upon whether you have a really stiff ARDS lung or not. So take home, again, don't weaponize the ventilator. Driving pressure less than 15 will probably be good enough for most of your patients. Mechanical power is very attractive. Again, I think the key is it's giving you a single-digit readout of several complex parameters, all that we know are associated with ventilator-induced lung injury, and it can help determine this safe versus injurious ventilation. I think simplified formulas at this point are fine based on the literature, but the thresholds, again, remained indeterminate. I would just say the lower is the better. So thank you very much.
Bueno, muchísimas gracias al doctor Richard Ockler por su intervención. Los invitamos en este momento a que se puedan dirigir al auditorio central, donde tendremos un refrigerio y visita nuevamente a nuestros aliados estratégicos. En este momento se pueden dirigir al auditorio central y los esperamos nuevamente aquí para continuar con nuestra jornada a las 10:15 de la mañana.
Vive una experiencia memorable en Los Cobos Medical Center. Al norte de Bogotá se encuentra una institución de servicios de salud integral que se destaca por su modelo de atención centrado en el paciente y su familia. Los Cobos Medical Center cuenta con un equipo de profesionales multidisciplinario, altamente capacitados, que se encargan del tratamiento de los pacientes, el cuidado y mejoría de la enfermedad, bajo un modelo de atención humanizado, que responde a sus necesidades y a las de su familia. Tiene a disposición las unidades funcionales como son: servicio de urgencias, servicio de unidad de cuidado intensivo. Este servicio funciona bajo el concepto de UCI abierta, diseñado para que un miembro de la familia pueda acompañar al paciente las 24 horas del día, con el objetivo de favorecer su mejoría. Servicio de cirugía de alta complejidad. Las salas de cirugía cuentan con un sistema de telemedicina que permite la visualización de exámenes diagnósticos de apoyo, y en caso de requerirse, conexión con médicos externos. Además, permiten la transmisión de la cirugía al auditorio y a las salas de educación. Servicio de hospitalización. Todas las habitaciones están diseñadas bajo las siguientes especificaciones: confort visual, gracias a una vista privilegiada de 180 grados hacia los paisajes de Bogotá y al jardín flotante exterior. Paneles integrados de atención para la seguridad del paciente. Diseño de ventilación y control acústico, lo cual genera un ambiente acogedor. Servicio ambulatorio, consulta externa. Imágenes diagnósticas entre las que están Adicionalmente, se cuenta con habitación para la prestación del servicio de medicina nuclear y procedimientos de radiología intervencionista. Los Cobos Medical Center cuenta con 6 programas especiales para la atención de pacientes cohortizados de Los Cobos Medical Center es una de las instituciones en salud más modernas de América Latina, con su diseño sostenible ambientalmente. Cuenta con amplios espacios, relajantes, con luz natural, diseñados especialmente para la comodidad y bienestar del paciente durante su estancia. En Los Cobos Medical Center, tú le perteneces a la vida, ya que es un centro de salud integral, donde el conocimiento médico, científico y académico se unen para que los pacientes vivan una experiencia memorable.
Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks. Ultomiris was built on the foundation of its predecessor, eculizumab, but has been modified to prolong its half-life. Both Ultomiris and eculizumab bind with high affinity to complement protein C5 in blood, thereby inhibiting its cleavage to C5a and C5b and preventing the generation of the terminal complement complex C5b9. One way in which Ultomiris and eculizumab differ is how they behave after binding to C5. Ultomiris is designed to release C5 in the endosome as pH levels drop, allowing it to bind with FcRn and be recycled back into the bloodstream where it can bind and neutralize additional C5. To further facilitate the recycling of Ultomiris, it has also been designed to bind to FcRn with greater affinity. The released C5 is then degraded by a lysosome. With eculizumab, binding to C5 inhibits FcRn-mediated recycling, leading to its lysosomal degradation along with C5. Through its modifications, Ultomiris has an approximately 4-fold longer half-life than eculizumab and provides immediate, complete, and sustained inhibition of C5. Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks.
Una experiencia de más de 67 años nos ha convertido en líderes en el mercado colombiano en la distribución de equipos y dispositivos médicos. Esto, sumado a un talento humano experto en el acompañamiento, distribución y mantenimiento, brindando soluciones oportunas y acertadas para la atención integral en salud. Pero, ¿qué hay detrás de esto? ¿Qué nos ha impulsado para seguir nuestro propósito corporativo? Aquí, más de 140 personas nos movemos al ritmo de las tendencias, buscando oportunidades, aportando nuestro conocimiento y experiencia por un mismo fin. Porque sabemos que no solo distribuimos equipos y dispositivos o brindamos un servicio de apoyo, porque sabemos que nuestro propósito impacta finalmente en la salud y bienestar de los pacientes, llevando esperanza de vida en los momentos que más lo necesitan. Porque nos apasiona trabajar unidos por un objetivo, porque somos expertos en lo que hacemos y porque innovamos para llevar a otro nivel el cuidado de la salud. En G-Barco, juntos, cuidamos la vida.
AVI sigue impactando la salud de los recién nacidos prematuros en el manejo del síndrome de dificultad respiratoria. Por más bebés en casa y menos en el hospital. Survanta es el surfactante seguro y eficaz para el tratamiento óptimo de bebés con síndrome de dificultad respiratoria del recién nacido prematuro. La Guía Colombiana de Práctica Clínica del Recién Nacido con Trastorno Respiratorio recomienda la aplicación de Survanta a dosis de 100 miligramos por kilo de peso. Survanta, dentro de sus múltiples beneficios, brinda mejor distribución de surfactante por su mayor volumen. Survanta cuenta con un sistema cerrado de administración que ofrece importantes beneficios para el bebé prematuro. Asegura una distribución uniforme en ambos bronquios. Menor riesgo de episodios de desaturación y bradicardia. No es necesario desconectar el bebé del ventilador. Menor riesgo de infección. Precisión en el sitio anatómico de aplicación. Permite el reclutamiento óptimo y logra una administración más segura del surfactante. Survanta se debe considerar como una excelente opción para el manejo del síndrome de dificultad respiratoria por respaldo en la Guía de Práctica Clínica Colombiana. Sistema cerrado de administración. Estudios de eficacia con experiencia de 29 años en el mercado. Soporte en recolección, disposición final de residuos y trazabilidad del producto. Respaldo de AVI en términos de farmacovigilancia. Por todos estos beneficios, Survanta es el surfactante de mayor uso por los médicos en Colombia.
Live a memorable experience at Los Cobos Medical Center. In the north of Bogota, there is a comprehensive health services institution which stands out for its care model, focused on patients and their families. The institution has a team of highly trained multidisciplinary professionals for the care of our patients, for the treatment and recovery of their illnesses, under a humanized care model that responds to their needs and those of their families. There are many functional units available, such as an emergency department, intensive care unit. This service works under an open ICU concept, designed in such a way that family members can accompany patients 24 hours a day, with the aim of promoting their improvement. High complexity surgeries. The surgery rooms have a telemedicine system that allows the viewing of supportive diagnostic exams and, if required, connection with external doctors. In addition, they allow transmissions to the auditorium and education rooms. Hospitalization. All rooms are designed under the following specifications. Visual comfort, thanks to a privileged 180-degree view towards the landscapes of Bogota and the exterior floating garden. Integrated care panels for patient safety. Ventilation and acoustic control design, which help generate a cozy environment. Ambulatory. External consultation and diagnostic images. Diagnostic images such as its facilities are habilitated for the provision of nuclear medicine services and interventional radiology procedures. Los Cobos Medical Center has 6 special programs for the care of cohortized patients of Los Cobos Medical Center is one of the most modern health institutions in Latin America, with its environmentally sustainable design. It has large relaxed spaces with natural light, specially designed for the comfort of the patient, aiming towards transmitting well-being during their stay. At Los Cobos Medical Center, you belong to life, in the care of a health center where medical, scientific, and academic knowledge come together so that patients live a memorable experience.
Vive una experiencia memorable en Los Cobos Medical Center. Al norte de Bogotá se encuentra una institución de servicios de salud integral que se destaca por su modelo de atención centrado en el paciente y su familia. Los Cobos Medical Center cuenta con un equipo de profesionales multidisciplinario, altamente capacitados, que se encargan del tratamiento de los pacientes, el cuidado y mejoría de la enfermedad, bajo un modelo de atención humanizado, que responde a sus necesidades y a las de su familia. Tiene a disposición las unidades funcionales como son: servicio de urgencias, servicio de unidad de cuidado intensivo. Este servicio funciona bajo el concepto de UCI abierta, diseñado para que un miembro de la familia pueda acompañar al paciente las 24 horas del día, con el objetivo de favorecer su mejoría. Servicio de cirugía de alta complejidad. Las salas de cirugía cuentan con un sistema de telemedicina que permite la visualización de exámenes diagnósticos de apoyo y, en caso de requerirse, conexión con médicos externos. Además, permiten la transmisión de la cirugía al auditorio y a las salas de educación. Servicio de hospitalización. Todas las habitaciones están diseñadas bajo las siguientes especificaciones. Confort visual, gracias a una vista privilegiada de 180 grados hacia los paisajes de Bogotá y al jardín flotante exterior. Paneles integrados de atención para la seguridad del paciente. Diseño de ventilación y control acústico, lo cual genera un ambiente acogedor. Servicio ambulatorio. Consulta externa. Imágenes diagnósticas entre las que están Adicionalmente, se cuenta con habitación para la prestación del servicio de medicina nuclear y procedimientos de radiología intervencionista. Los Cobos Medical Center cuenta con 6 programas especiales para la atención de pacientes cohortizados de Los Cobos Medical Center es una de las instituciones en salud más modernas de América Latina, con su diseño sostenible ambientalmente. Cuenta con amplios espacios, relajantes, con luz natural, diseñados especialmente para la comodidad y bienestar del paciente durante su estancia. En Los Cobos Medical Center, tú le perteneces a la vida, ya que es un centro de salud integral, donde el conocimiento médico, científico y académico se unen para que los pacientes vivan una experiencia memorable.
Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks. Ultomiris was built on the foundation of its predecessor, eculizumab, but has been modified to prolong its half-life. Both Ultomiris and eculizumab bind with high affinity to complement protein C5 in blood, thereby inhibiting its cleavage to C5a and C5b and preventing the generation of the terminal complement complex C5b9. One way in which Ultomiris and eculizumab differ is how they behave after binding to C5. Ultomiris is designed to release C5 in the endosome as pH levels drop, allowing it to bind with FcRn and be recycled back into the bloodstream where it can bind and neutralize additional C5. To further facilitate the recycling of Ultomiris, it has also been designed to bind to FcRn with greater affinity. The released C5 is then degraded by a lysosome. With eculizumab, binding to C5 inhibits FcRn-mediated recycling, leading to its lysosomal degradation along with C5. Through its modifications, Ultomiris has an approximately 4-fold longer half-life than eculizumab and provides immediate, complete, and sustained inhibition of C5. Ultomiris is the first and only FDA-approved long-acting complement inhibitor that provides immediate and complete C5 inhibition sustained for up to 8 weeks.
Una experiencia de más de 67 años nos ha convertido en líderes en el mercado colombiano en la distribución de equipos y dispositivos médicos. Esto, sumado a un talento humano experto en el acompañamiento, distribución y mantenimiento, brindando soluciones oportunas y acertadas para la atención integral en salud. Pero, ¿qué hay detrás de esto? ¿Qué nos ha impulsado para seguir nuestro propósito corporativo? Aquí, más de 140 personas nos movemos al ritmo de las tendencias, buscando oportunidades, aportando nuestro conocimiento y experiencia por un mismo fin. Porque sabemos que no solo distribuimos equipos y dispositivos o brindamos un servicio de apoyo, porque sabemos que nuestro propósito impacta finalmente en la salud y bienestar de los pacientes, llevando esperanza de vida en los momentos que más lo necesitan. Porque nos apasiona trabajar unidos por un objetivo, porque somos expertos en lo que hacemos y porque innovamos para llevar a otro nivel el cuidado de la salud. En G-Barco, juntos, cuidamos la vida.
AVI sigue impactando la salud de los recién nacidos prematuros en el manejo del síndrome de dificultad respiratoria. Por más bebés en casa y menos en el hospital. Survanta es el surfactante seguro y eficaz para el tratamiento óptimo de bebés con síndrome de dificultad respiratoria del recién nacido prematuro. La Guía Colombiana de Práctica Clínica del Recién Nacido con Trastorno Respiratorio recomienda la aplicación de Survanta a dosis de 100 miligramos por kilo de peso. Survanta, dentro de sus múltiples beneficios, brinda mejor distribución de surfactante por su mayor volumen. Survanta cuenta con un sistema cerrado de administración que ofrece importantes beneficios para el bebé prematuro. Asegura una distribución uniforme en ambos bronquios. Menor riesgo de episodios de desaturación y bradicardia. No es necesario desconectar el bebé del ventilador. Menor riesgo de infección. Precisión en el sitio anatómico de aplicación. Permite el reclutamiento óptimo y logra una administración más segura del surfactante. Survanta se debe considerar como una excelente opción para el manejo del síndrome de dificultad respiratoria por respaldo en la Guía de Práctica Clínica Colombiana. Sistema cerrado de administración. Estudios de eficacia con experiencia de 29 años en el mercado. Soporte en recolección, disposición final de residuos y trazabilidad del producto. Respaldo de AVI en términos de farmacovigilancia. Por todos estos beneficios, Survanta es el surfactante de mayor uso por los médicos en Colombia.
Live a memorable experience at Los Cobos Medical Center. In the north of Bogota, there is a comprehensive health services institution, which stands out for its care model, focused on patients and their families. The institution has a team of highly trained multidisciplinary professionals for the care of our patients, for the treatment and recovery of their illnesses, under a humanized care model that responds to their needs and those of their families. There are many functional units available, such as an emergency department, intensive care unit. This service works under an open ICU concept, designed in such a way that family members can accompany patients 24 hours a day, with the aim of promoting their improvement. High complexity surgeries. The surgery rooms have a telemedicine system that allows the viewing of supportive diagnostic exams and, if required, connection with external doctors. In addition, they allow transmissions to the auditorium and education rooms. Hospitalization. All rooms are designed under the following specifications. Visual comfort, thanks to a privileged 180-degree view towards the landscapes of Bogota and the exterior floating garden. Integrated care panels for patient safety. Ventilation and acoustic control design, which help generate a cozy environment. Ambulatory. External consultation and diagnostic images. Diagnostic images such as its facilities are habilitated for the provision of nuclear medicine services and interventional radiology procedures. Los Cobos Medical Center has 6 special programs for the care of cohortized patients of Los Cobos Medical Center is one of the most modern health institutions in Latin America, with its environmentally sustainable design. It has large relaxed spaces with natural light, specially designed for the comfort of the patient, aiming towards transmitting well-being during their stay. At Los Cobos Medical Center, you belong to life. In the care of a health center where medical, scientific, and academic knowledge come together so that patients live a memorable experience.
Vive una experiencia memorable en Los Cobos Medical Center. Al norte de Bogotá, se encuentra una institución de servicios de salud integral que se destaca por su modelo de atención centrado en el paciente y su familia. Los Cobos Medical Center cuenta con un equipo de profesionales multidisciplinario, altamente capacitados, que se encargan del tratamiento de los pacientes, el cuidado y mejoría de la enfermedad, bajo un modelo de atención humanizado, que responde a sus necesidades y a las de su familia. Tiene a disposición las unidades funcionales como son servicio de urgencias, Servicio de unidad de cuidado intensivo. Este servicio funciona bajo el concepto de UCI abierta, diseñado para que un miembro de la familia pueda acompañar al paciente las 24 horas del día, con el objetivo de favorecer su mejoría. Servicio de cirugía de alta complejidad. Las salas de cirugía cuentan con un sistema de telemedicina que permite la visualización de exámenes diagnósticos de apoyo y, en caso de requerirse, conexión con médicos externos. Además, permiten la transmisión de la cirugía al auditorio y a las salas de educación. Servicio de hospitalización. Todas las habitaciones están diseñadas bajo las siguientes especificaciones. Confort visual, gracias a una vista privilegiada de 180 grados hacia los paisajes de Bogotá y al jardín flotante exterior. Paneles integrados de atención para la seguridad del paciente. Diseño de ventilación y control acústico, lo cual genera un ambiente acogedor. Servicio ambulatorio. Consulta externa. Imágenes diagnósticas entre las que están Adicionalmente, se cuenta con habitación para la prestación del servicio de medicina nuclear y procedimientos de radiología intervencionista. Los Cobos Medical Center cuenta con 6 programas especiales para la atención de pacientes cohortizados de Los Cobos Medical Center es una de las instituciones en salud más modernas de América Latina, con su diseño sostenible ambientalmente. Cuenta con amplios espacios, relajantes, con luz natural, diseñados especialmente para la comodidad y bienestar del paciente durante su estancia. En Los Cobos Medical Center, tú le perteneces a la vida, ya que es un centro de salud integral, donde el conocimiento médico, científico y académico se unen para que los pacientes vivan una experiencia memorable.
Bueno, agradecemos nuevamente su permanencia en el auditorio principal de la Universidad del Bosque, igualmente a las personas que se encuentran al ingreso, que puedan seguir y tomar nuevamente asiento para continuar con nuestra jornada del día de hoy. Antes de continuar, quiero llamar a la persona Lidia Mercedes Palacios, si se encuentra presente en el auditorio, para que por favor se pueda dirigir al ingreso del mismo que le estamos solicitando. Continuando entonces, seguimos con la conferencia titulada Maniobras de reclutamiento y métodos de titulación de PEEP, a cargo del doctor Gustavo Cortés Puentes de Mayo Clinic. Conozcamos igualmente un poco más acerca del doctor. El doctor Gustavo Cortés Puentes es profesor asistente de Medicina y Fisiología en Mayo Clinic y consultor en la División de Medicina Pulmonar y de Cuidados Críticos en Mayo Clinic Rochester. Y actualmente es un Mayo Clinic Care Scholar, un prestigioso reconocimiento de investigación otorgado a investigadores destacados por su compromiso con la innovación. Después de completar su residencia en medicina interna en la Universidad de Minnesota, realizó un fellowship en neumología y medicina de cuidados críticos en Mayo Clinic en Rochester, igualmente en Minnesota, seguido de un fellowship de investigación en mecánica pulmonar avanzada y fisiología respiratoria. Su investigación se centra en la medicina de cuidados críticos, con experiencia en estrategias de ventilación mecánica, función pulmonar y fisiología del ejercicio. También es el fundador y codirector de la Conferencia de Ventilación Mecánica de Mayo Clinic, una referencia mundial en educación sobre ventilación mecánica. Demos entonces la bienvenida al doctor Gustavo Andrés Cortés Puentes.
Buenos días a todos y muchísimas gracias de nuevo por la invitación. Quiero unirme también a el reconocimiento a los codirectores de esta conferencia, al doctor Cortés Puentes, al doctor Valencia, al doctor Ovalle, por todo el esfuerzo y la dedicación y la hospitalidad que nos han brindado al equipo de la Mayo. Y quiero decir también que estamos muy gratamente sorprendidos por el apetito académico y de colaboración que han mostrado todos los asistentes al Congreso. Muchísimas gracias. Y en los siguientes minutos quisiera hablar un poco acerca de las maniobras de reclutamiento y los métodos de titulación de PEEP. Los objetivos principales de esta charla van a ser principalmente reconocer la contribución específica de la complacencia pulmonar y de la pared torácica en la mecánica pulmonar, específicamente cuando los pacientes están en ventilación mecánica de presión positiva, y también aplicar estrategias de reclutabilidad pulmonar y aprender algunos métodos de titulación del PEEP, que muy seguramente ustedes conocen, pero que me gustaría explorar de manera muy práctica el día de hoy. Siempre que pensamos en titulación de PEEP y qué nivel de PEEP necesita nuestro paciente, debemos hacer una pausa y tratar de identificar que la compliance del sistema respiratorio se compone tanto del compliance del pulmón como del compliance de la pared torácica. Y esta compliance puede ser alta o baja debido a la contribución o del tejido pulmonar o de la pared torácica. Entonces, desde el punto de vista clínico, nuestro principal objetivo es tratar de identificar cuál es el jugador principal en esa ecuación. Y el segundo punto que es supremamente importante para la titulación del PEEP es entender el concepto de reclutabilidad pulmonar. Debemos saber y poder responder a la pregunta, ¿son los pulmones de este paciente reclutables o no? Y vamos a explorar un poco por qué consideramos que esta pregunta es tan importante. Quiero dirigir su atención directamente a esta gráfica que fue publicada por el doctor Gattinoni en los primeros años del 2000. Y como pueden ver, hay básicamente dos pacientes aquí, representados en la parte superior y en la parte inferior de la gráfica. Pero antes de explorar esta diapositiva, quisiera que todos tomaran una respiración profunda conmigo y dejen salir el aire y traten de contestar ustedes la pregunta, ¿son sus pulmones reclutables ahora o no? ¿Quién me quiere contestar? Un voluntario. Gustavo, por allá. ¿Qué dices? No, la respuesta es no. Muy bien, muy bien. Espectacular. Esto me lleva a la diferencia, identificar la diferencia entre ser reclutable y tener una compliance pulmonar normal. Y como pueden ver en la primera imagen, en la primera imagen, este pulmón está insuflado a una presión de 5 centímetros de agua. Y si lo llevamos a una presión inspiratoria de 45 centímetros de agua, como pueden ver, hay unas consolidaciones pulmonares basales bilaterales que realmente persisten incluso a una muy alta presión. Si les pregunto si este pulmón es reclutable, ¿cuál sería la respuesta? No lo es, perfecto. Vamos a ver el segundo ejemplo. Como pueden ver, incluso hay unas consolidaciones aún más densas con broncogramas aéreos a nivel inspiratorio con una presión de 5 centímetros de agua. Pero si inflamos este pulmón a 45 centímetros de agua, las consolidaciones desaparecen significativamente. Entonces, este paciente es reclutable. Entonces, sus pulmones, asumiendo que ninguno tiene SDRA aquí atendiendo nuestra conferencia, son distendibles, tienen una compliance normal, pero no tienen un índice de reclutabilidad muy alto. Y en SDRA existe una gran distribución, una distribución bastante variada de este grado o este nivel de reclutabilidad. Y realmente no sigue necesariamente la clasificación de severidad que vemos en SDRA. Nuestros pacientes pueden ser reclutables o no reclutables en diferentes tipos de nivel de severidad del SDRA, como pueden ver en esta diapositiva. Y esto me lleva a explorar un poco la fisiología de la inflación y la expiración del pulmón cuando estamos en ventilación mecánica. Y como pueden ver, aquí hay muchísima información, pero a medida que la presión aumenta, el grado de inflación pulmonar realmente no cambia hasta que llegamos a un punto que es el punto de inflexión inferior, en donde drásticamente la inflexión del pulmón empieza a aumentar. Y como pueden ver, la presión continúa aumentando, pero el grado de ganancia de volumen pulmonar realmente como que se estanca un poco. Esta es la parte de la inflexión superior, en el cual el pulmón empieza a sobredistenderse. Pero quiero llamar la atención a esta, la flecha amarilla que pueden ver en la diapositiva, y como pueden ver, por el mismo nivel de presión a 8 centímetros de agua, tenemos realmente un nivel pulmonar de inflación totalmente diferente durante la inspiración comparado con la expiración. Y esto pues tiene que ver directamente con la presión y la tensión superficial alveolar, y entre más alta o más amplia sea esa flecha amarilla, el pulmón tiene una mayor capacidad de reclutabilidad y de distensión. Vamos a ver algunos ejemplos ahora. Aquí es una representación gráfica de lo mismo. Como pueden ver, a la misma presión pulmonar, por ejemplo acá, a alrededor de 8 centímetros de agua, el volumen pulmonar es bastante pequeño, pero durante la expiración el pulmón es capaz de mantener esa inflación y como de oponerse a la deflexión de la cantidad de volumen que vemos en el pulmón. Y nosotros usamos este concepto en algunos ventiladores para realizar una maniobra de inflación sostenida y evaluar esa distancia, evaluar esa flecha amarilla, y dependiendo de ciertos valores podemos hacer una evaluación de que si el pulmón es reclutable o no. Tenemos ciertos parámetros. Si a nivel de 20 centímetros de agua, la presión, la cantidad de volumen que tenemos y la diferencia de volumen entre la inspiración y la expiración es mayor de 500 milímetros de aire, podemos decir inmediatamente que el pulmón es reclutable. O si hacemos una maniobra de reclutabilidad, y esta es la única maniobra de reclutabilidad que hacemos en nuestra clínica, lo que hacemos es inflar el pulmón hasta una presión de 35 o 40 y sostenemos esa presión por alrededor de 8 a 10 segundos. Y al sostener esa presión vemos una ganancia de volumen. Cuando medimos esa ganancia de volumen, si esta ganancia de volumen es más de 2 centímetros por kilo de peso promedio del paciente, decimos que este es un paciente que es reclutable. También podemos hacer la relación entre el volumen y el porcentaje que ganamos relativamente al sostener esta presión por 10 a 8 segundos, y si es más del 30 o el 40%, también podemos tener un índice de reclutabilidad. Sin embargo, por supuesto, no todas las instituciones tienen acceso a estas herramientas. Entonces, la pregunta es, ¿cómo podemos hacerlo un poco más sencillo cuando estamos al lado del paciente? Entonces, tengo aquí algunos ejemplos que quizás son un poco drásticos, pero son para ilustrar y llevar el punto a casa. Tenemos este paciente ventilado con volumen corriente, en volumen control, con un volumen corriente de 6 centímetros por kilo de peso ideal del paciente. Como pueden ver, está a un volumen corriente de 410 y tiene un PEEP de 10 y una respiración de 17. Y si hacemos la examinación de la mecánica pulmonar de este paciente, vamos a hacer una pausa inspiratoria que tenemos acá, lo cual nos resulta en una presión plató de 14.7, y por supuesto con un PEEP de 10 tenemos un driving pressure de 4.7. Como revisamos con el doctor Ocler, la diferencia entre el plató y el PEEP es lo que nos va a dar, cuando tenemos volumen corriente y tenemos un flujo constante, la presión del driving pressure. Entonces, si hacemos un trial de PEEP, tenemos el PEEP iniciando a 10 y lo incrementamos a 15, y hacemos de nuevo una pausa inspiratoria, la presión plató es 19.8, aumentó, pero como pueden ver, el driving pressure básicamente quedó lo mismo. Entonces, lo que indica esto es que al no haber el cambio del driving pressure por el mismo volumen corriente, estamos abriendo el pulmón mucho más y por tanto tenemos un espacio más amplio, el pulmón se reclutó y podemos acomodar ese volumen corriente a una menor presión y este paciente podemos declararlo reclutable en teoría. Vamos a ver otro ejemplo un poquito diferente. En este tenemos un PEEP de 5, mucho más bajo que el ejemplo anterior. Hacemos de nuevo una pausa inspiratoria y tenemos acá una presión plató de 27.2. Por supuesto, el driving pressure es bastante alto, 22.2. Y si hacemos un ensayo de PEEP, aumentando el PEEP a 10, por ejemplo, la presión plató, por supuesto, aumenta muchísimo más. Y ahora el driving pressure es 27.3. Entonces, claramente, con un cambio de presión del PEEP de solo 5 centímetros de agua, la presión del driving pressure aumentó por casi 10 centímetros de agua. Entonces, es muy realmente lógico, y de nuevo, estos dos ejemplos son extremos, pero es para que llevemos la idea de que el driving pressure también nos puede ayudar no solamente para examinar que el paciente se está empeorando o está mejorando, pero también puede ser un marcador para titular el PEEP. Y esto lo podemos hacer sin necesidad de tener una curva de presión-volumen. Y este paciente, por supuesto, es no reclutable. Si hacemos la presión, nuestros ventiladores hacen una curva de presión-volumen y como pueden ver, la flecha amarilla es bastante pequeña. Un paciente que no es reclutable, esto se llama histeresis, tiene una histeresis bastante pequeña. Y eso es lo que tratamos de identificar. Es como un patrón de reconocimiento. Cuando ves la curva, realmente sabes muy fácilmente si el paciente es reclutable o no. Quiero hacer una pausa aquí porque muchos de los ventiladores tienen la curva de presión. Lo podemos ver en las pantallas y está continuamente rotando. Esa no es la curva que debemos mirar. Esto es una curva dinámica. Quiere decir que integra la parte de resistencia de la vía aérea a la curva y no nos deja hacer un examen juicioso de la reclutabilidad del paciente. Esto es una curva estática, lo que quiere decir que se construyó con una insuflación sostenida de una cierta cantidad de aire por una cierta cantidad de tiempo y no tiene realmente influencia de la resistencia en el paciente. Es importante recordar eso. Esto es una diapositiva que a mí me gusta mucho porque realmente representa que el método no es tan importante. Hay muchísimos métodos para titular PEEP y si le pusiera una bandera a cada método, eso se vería como las Naciones Unidas. Hay un estudio prácticamente por cada país y la peculiaridad de todos estos estudios y todos estos métodos es que examinan la mecánica pulmonar, pero realmente no han demostrado un beneficio en la mortalidad del paciente. Y realmente ahora que sabemos un poco más acerca de la importancia de la reclutabilidad, podemos entender por qué. Entonces, acá los hemos organizado un poco de acuerdo al target que vamos a seguir o la solución principal que vamos a seguir para titular el PEEP. Entonces, tenemos unos métodos que miran básicamente la mecánica pulmonar, específicamente la parte de la inflación o el proceso o la fase de inflación de la respiración mecánica. Tenemos otros métodos que siguen la oxigenación del paciente y tenemos otros métodos que utilizan herramientas que vamos a revisar en las siguientes diapositivas. También podemos usar ultrasonido. Aquí vimos muchísimo material de discusión acerca de ultrasonido y también podemos usar capnografía volumétrica para titular el PEEP. Pero realmente son métodos que son un poco complicados, requieren muchísimo instrumento y requieren muchísima experticia y no son muy aplicables, especialmente cuando tenemos cambio de turno y diferentes proveedores que están cuidando al mismo paciente. Esta es la clásica tabla de PEEP y FiO2 y realmente pues esto es un consenso de expertos, realmente no sigue ninguna fisiología. Tú puedes decidir si favoreces o el FiO2 o el PEEP, pero realmente no han demostrado tampoco una clara relación con la mejoría de la mortalidad en el paciente. Y esta diapositiva es un ejemplo claro de qué es lo que no se debe hacer en maniobras de reclutabilidad. Lo que representamos aquí es la maniobra de reclutabilidad de Borges, que es la misma que se utilizó en el en el clinical trial de ARTS trial, que miró la parte de reclutabilidad y cuál era la influencia en la mortalidad de los pacientes con SDRA. Y tiene básicamente 3 sectores que sí son importantes reconocer. La primera es la parte de reclutamiento pulmonar. Esto se hace en un modo de presión y usualmente la presión soporte que se usa, asumiendo que esta es el driving pressure, se utiliza menos de 15 centímetros de agua. Y como pueden ver, esa presión, ese driving pressure, se envía sobre diferentes niveles de PEEP. Ahí tenemos 25, 35 y 45. Lo que quiere decir que la presión inspiratoria de estos pacientes alcanza niveles tan absurdos como 60 centímetros de agua. Por supuesto, incluso durante esta corta, entre comillas, 4 o 5 minutos maniobra, los pacientes en este estudio empezaron a experimentar colapso cardiovascular y después hubo una modificación del protocolo, y esto es directamente del estudio, en el cual dijeron, bueno, de pronto 60 es mucho, vamos a disminuir a 50. Y de todas maneras todavía los pacientes siguieron muriendo. Entonces, después de hacer esta maniobra de reclutabilidad, lo que sucede es que hacemos un ensayo de PEEP. Y lo que hacemos es sencillamente usar niveles diferentes de PEEP, 25, 20, 17, etcétera. Y lo que seguimos es la complacencia del sistema respiratorio. O sea que lo que miramos es que de pronto 23 es mucho PEEP y estamos sobredistendiendo el paciente. Si seguimos la complacencia del sistema respiratorio y vemos que a medida que disminuimos el PEEP, la complacencia del sistema respiratorio aumenta, entonces eso quiere decir que estamos llegando a ese sweet spot, a ese punto ideal del PEEP que queremos. Si seguimos disminuyendo el PEEP, la complacencia de repente disminuye de nuevo, lo que quiere decir que el PEEP adecuado es el anterior. Y después de hacer ese ensayo, identificar ese número, hacemos de nuevo una maniobra de reclutamiento, de nuevo aumentando las presiones a 50, 60, y finalmente el paciente se deja en el PEEP que identificamos. Pero como pueden ver, esta maniobra dura 20, 30 minutos. Y lo que hemos identificado es que realmente ningún pulmón necesita estar inflado de esa manera por tanto tiempo. Realmente si miramos al concepto del time constant, uno solamente necesita entre 2 y 3 times constant para realmente inflar y sacar el aire del pulmón en menos de 10 o 8 segundos. Entonces, eso es el tiempo en el cual utilizamos la maniobra de reclutamiento en nuestra práctica clínica. También podemos usar otros métodos que, de nuevo, examinan la parte inspiratoria del pulmón. Esto es el Stress Index y realmente es una maniobra que se utilizaba muchísimo en la sala de cirugía. Y hay una regla de 3 que es muy fácil de recordar. Lo que tenemos que hacer es tener el paciente en volumen corriente. Tenemos que disminuir el flujo, el peak flow lo disminuimos a 10 litros por minuto y disminuimos la frecuencia respiratoria alrededor de 10. La razón por la cual hacemos eso es para hacer flujos muy lentos, hacer la inflación de ese pulmón supremamente suave para eliminar cualquier influencia de la resistencia de las vías aéreas. Y lo que hacemos básicamente es observar el comportamiento de la fase inspiratoria del paciente. Como pueden ver acá, vamos a ver, siguiente diapositiva, aquí tenemos un Stress Index que es menos de 1 y como pueden ver la inflación, el envío del volumen corriente se hace básicamente empezando con un pulmón que está colapsado y a medida que el volumen corriente se envía hacia el pulmón, como pueden ver, la curva baja, o sea, la presión baja más o menos a la mitad de la inspiración. Lo que quiere decir que de manera abrupta hemos abierto el pulmón, reclutado el pulmón a la mitad de la inspiración, lo que quiere decir que muy seguramente el paciente se beneficiaría de que ese volumen corriente se envíe a un pulmón que tiene un PEEP más alto. Aquí en la mitad es el Stress Index que queremos lograr, que es el Stress Index de 1. Lo que queremos es movernos de un pulmón que está normalmente inflado sin mucha área colapsada o sin mucha telectasia y lo inflamos a un punto que no es de sobredistensión. Entonces, ese es el Stress Index que queremos. Siempre queremos una línea recta durante la inspiración en esta maniobra y lo contrario ocurre cuando el PEEP está inapropiadamente alto. Como podemos ver, la inflación al final de la expiración es bastante alto, el PEEP está inadecuadamente alto, el volumen corriente se envía y hay sobredistensión. Debido a esa sobredistensión, la curva aumenta. Entonces, cuando vemos esa curva hacia arriba, quiere decir que el paciente se beneficiaría de un nivel de PEEP mucho más bajo. Entonces, realmente es una manera gráfica de examinar y, de nuevo, la parte principal es tener las condiciones específicas para hacer esto bien. Muchas veces la gente mira a la curva sin hacer estas modificaciones y el comportamiento que vemos en la curva puede ser debido a secreciones o a resistencia o a broncoespasmo, etcétera, etcétera. Entonces, tenemos que tener las condiciones correctas. Y esto me lleva a una herramienta que realmente no es nueva, pero que se ha usado probablemente en los últimos 10 años, que es la manometría esofágica. Como pueden ver acá, esto es básicamente un catéter, este es el balón esofágico, y en este sector del balón esofágico, el catéter está cubierto con un balón neumático, y ese sector que está cubierto con el balón neumático tiene unos orificios de manera espiral. Y lo hacemos de manera espiral para asegurarnos que si hay un sector del esófago que no está en posicionamiento adecuado con el catéter, de todas maneras hay otros orificios que son capaces de sensar esa presión. Y usamos este catéter básicamente como una medida subrogada de la presión pulmonar. Como no podemos tener un probe de presión en el pulmón sin generar un neumotórax, entonces hacemos una medición de la presión esofágica para titular el PEEP. Y realmente es muy básico. Con lo que jugamos aquí es el concepto de la presión transpulmonar. Y muy parecido a lo que el doctor Mancat nos estaba diciendo más temprano acerca de la presión transmural. La presión transpulmonar es la presión que es responsable por la inflación alveolar o por el colapso alveolar. Y es básicamente la relación que existe entre la presión alveolar y la presión de la pleura, que medimos en este caso con la presión esofágica. Lo que quiere decir que si la presión alveolar es muchísimo más alta que la presión alrededor del alveolo, que está representada por la presión pleural o la presión esofágica, el alveolo va a estar inflado. Si el alveolo está rodeado de una presión que es muchísimo más alta que la presión que tenemos adentro del alveolo, la presión transpulmonar va a ser negativa, lo cual significa que el alveolo se va a colapsar. Entonces tenemos dos presiones transpulmonares, una al final de la expiración, en donde la presión alveolar está representada por el PEEP total del paciente. Quiere decir que tenemos que tener en cuenta no solamente el PEEP que estamos programando en el ventilador, pero también el PEEP que puede estar relacionado con auto-PEEP. Entonces, cuando hacemos esta medida con la presión esofágica, tenemos que hacer una pausa expiratoria para medir la presión total al final de la expiración, para asegurarnos que el cálculo está correcto y que realmente incluye el PEEP intrínseco. Una vez hacemos la inflación del paciente o llevamos al pulmón el volumen corriente, vamos a tener la segunda presión transpulmonar, y es la relación entre la presión plató y la presión esofágica que medimos a nivel inspiratorio. Y básicamente lo que queremos es que ambas presiones sean positivas y que la presión al nivel expiratorio sea básicamente mayor de 0. Entonces lo que hacemos es titular el PEEP. Si hacemos la medida y la presión transpulmonar a nivel expiratorio es vamos a decir, -5, entonces puedo aumentar el PEEP de 5 a 10 para hacer esa presión transpulmonar 0 o positiva 1 o positiva 2. Y la presión inspiratoria transpulmonar la queremos menos de 20, lo que quiere decir que si tenemos un PEEP muy inapropiado y después de hacer la modificación basado en la presión expiratoria, todavía la presión inspiratoria es más de 20, podemos disminuir el volumen corriente. Entonces la presión esofágica nos sirve tanto para titular el PEEP como para titular el volumen corriente también del paciente. Todo esto suena supremamente bien, pero han habido dos estudios de nuevo. El primero, el EPIVENT-1, que mostró básicamente que la oxigenación mejora, por supuesto, y que se tiene una mejor complacencia pulmonar, pero realmente no hubo relación con el mejoramiento de la mortalidad del paciente. El segundo estudio, el EPIVENT-2, básicamente demostró de nuevo que no hay un cambio en la mortalidad, pero hay una relación muy cercana entre medir la presión esofágica y la tabla de alto PEEP y FiO2 que miramos anteriormente del RNETs, que mostré hace unas diapositivas atrás. Y esto no quiere decir que no se deba usar, es una representación de que muchas veces no es la flecha que utilizamos, sino quién la está utilizando. La herramienta es muy buena, mide lo que tiene que medir, pero hay una constelación de factores que se deben tener en cuenta para titular el PEEP. Y esta imagen es fascinante, es una adaptación de un análisis de aireación de muchos pacientes con SDRA que se hicieron en Italia. Y lo que muestra es básicamente la frecuencia en el cual los alvéolos se abren y la presión a la cual ese porcentaje de alvéolos se ha abierto. Y como pueden ver, a la misma presión, incluso a presiones tan altas como 45 y 50, algunos alvéolos no solamente se están abriendo, pero también cerrando. Y esta interacción interalveolar nos permite tener en cuenta que quizás el concepto de abrir y cerrar el pulmón y prevenir el atelectrauma no sea quizás algo que debamos enfocarnos muchísimo. Ahora quiero que reflexionemos un poco en todos los pacientes que hemos ventilado. Normalmente el volumen corriente se mantiene muy juiciosamente entre 6 y 8 centímetros por kilo de peso ideal. Y si pensamos en todos los PEEPs que hemos titulado en nuestras UCIs, la mayoría son 5, 8, 10, 12, realmente, ¿right? Entonces, alrededor de 10, más o menos 5, ¿cierto? Entonces, más o menos nos movemos en una presión al final de la expiración en este rango. Y por supuesto, todos sabemos que la presión plató debe mantenerse alrededor de 30 o menos. Entonces, realmente, si nos ponemos a pensar cuál es ese atelectrauma que nos debe preocupar, pues muy seguramente es solamente ¿no? Y el porcentaje y la importancia y la relevancia clínica quizás no sea tan significativa. Y esto me lleva a la importancia que tiene, y la charla del doctor Mankat fue supremamente importante esta mañana, porque cuando intentamos siempre mantener el pulmón abierto y tener una estrategia pulmonar abierta que estuvo muchísimo de moda hace una década, empezamos a sacrificar el compromiso cardiovascular o la relación cardiopulmonar del paciente. Y como el doctor Mankat explicó esta mañana, la relación entre la presión, la resistencia vascular pulmonar y el volumen corriente pulmonar es supremamente importante. Como explicó el doctor Mankat esta mañana, hay dos tipos de vasos sanguíneos que debemos tener en cuenta: esos vasos intraalveolares y esos vasos extraalveolares que están representados por el punto azul en la diapositiva. Cuando la inflación del pulmón ocurre, la presión intraalveolar aumenta y estos vasos sanguíneos intraalveolares se van a comprimir. Por tanto, la resistencia vascular pulmonar de esos vasos sanguíneos va a aumentar, representados allí por la curva roja. Sin embargo, como el pulmón se está inflando y los alveolos se están inflando, existen estas tensiones intersticiales que básicamente hablan de los vasos sanguíneos extraalveolares. Y como pueden ver, el punto azul que representa esos vasos sanguíneos se hace más grande y por tanto la presión vascular o la resistencia vascular pulmonar disminuye, como está representado acá en la curva azul. Entonces, cuando combinamos esas dos curvas, el resultado es la relación en U que existe entre la presión, la resistencia vascular pulmonar y el volumen pulmonar del paciente. Entonces, ¿cómo se aplica esto al paciente que estamos viendo en nuestra UCI? La mejor relación, o sea, los dos factores, tanto el nivel pulmonar y la oxigenación como el desempeño cardiovascular, están ambos más contentos cuando el nivel pulmonar de aireación está cercano a la capacidad residual funcional del paciente. Lo que quiere decir es que si envío este volumen corriente de este tamaño sobre un volumen al final de la inspiración que está muy cerca del FRC o de la capacidad funcional residual, voy a generar un cambio en la resistencia pulmonar vascular que quizás no es muy grande. Pero si tengo un PEEP que está inapropiadamente alto, por el mismo tamaño de volumen corriente, el cambio de la resistencia vascular pulmonar es significativo. lo que quiere decir que en ese caso el paciente se beneficiaría por un PEEP más bajo. Pero la historia no solamente pasa al lado derecho de la curva, sino también al lado izquierdo de la curva. Los pacientes que vemos en Rochester son muchísimo más comprometidos desde el punto de vista de peso. Recuerdo un BMI que tuve de 110, y no es el peso, es el BMI del paciente. Y por supuesto, la atelectasia y la pérdida del pulmón pulmonar es significativa en estos pacientes. Entonces, si el PEEP está muy bajo para el paciente, también la resistencia vascular pulmonar se ve afectada. Lo que quiere decir que tenemos que tener en cuenta tanto el efecto de recuperar el volumen del paciente, si el paciente tiene muchísima atelectasia o tiene un block pulmonar o un bloqueo mucoso que está tapando totalmente uno de los pulmones, recuperar el pulmón y llevarlo hacia el FRC es supremamente importante para mejorar el desempeño cardiovascular de este paciente desde el punto de vista del PEEP. Eso también me lleva, y muy interconectado con la discusión que tuvimos acerca de mechanical power más temprano, y es la relación que existe del PEEP con el strain o la distensión adversa del pulmón. Como podemos ver, el estrés quiere decir la tensión, quiere decir ese cambio de presión abrupto que existe entre las uniones pulmonares debido a los cambios de presión abruptos. Entonces, cuando pensamos en estrés, pensamos en la presión transpulmonar, pensamos en el driving pressure. Cuando pensamos en strain, eso quiere decir es la elongación sostenida del alveolo. Y está muy relacionado no solamente con el volumen tidal o el volumen corriente del paciente, pero también con el nivel del PEEP. Entonces, el PEEP puede realmente sostener o contribuir al desempeño o al desarrollo de la lesión pulmonar asociada al ventilador. Y esto es la razón por la cual el mechanical power o el poder mecánico de la estrategia de ventilación mecánica incluye también el PEEP. Entonces tenemos factores que básicamente son responsables de inflar el pulmón, o sea, de distender ese pulmón. Lo que tenemos ahí es básicamente el volumen corriente y la compliance del pulmón. Tenemos factores que son responsables por mover ese volumen corriente fuera y dentro del pulmón. Entonces pensamos en el I ratio o la tasa o la relación entre la inspiración y la expiración, la frecuencia respiratoria y la resistencia de la vía aérea. Y tenemos factores que son responsables por mantener el pulmón con un grado de inflación adecuado al final de la expiración. Entonces, todos estos componentes se entrelazaron en una variable que es el poder mecánico o el mechanical power, y realmente tiene incluido el PEEP por esa razón. Entonces, es muy importante tener en cuenta que el PEEP puede ser un factor fundamental para el desarrollo de la ventilación, de la lesión pulmonar asociada al ventilador. Entonces, como pueden ver, el PEEP óptimo no es el PEEP que titulamos con el Stress Index o el PEEP que titulamos con el balón esofágico o el PEEP que titulamos con la presión del driving pressure, sino que el PEEP es una constelación de factores que tenemos que ser responsables de analizar todos. Entonces, primero, ¿qué queremos hacer con el PEEP? Un PEEP óptimo es aquel que nos ayuda a oxigenar. Y es un PEEP que nos ayuda a oxigenar, ojalá con un suplemento de oxígeno que no se considere tóxico. Entonces, si pensamos en eso, un PEEP óptimo debe podernos resultar en una PO2 de 55 con una fricción de inspiración al menos de 60% o menos, ¿cierto? También el PEEP óptimo es aquel que nos permite mantener niveles de seguridad desde el punto de vista inspiratorio. Entonces, un PEEP óptimo es el que nos deja oxigenar, pero también es el que nos deja mantener una presión plató de menos de 30, por ejemplo. Y, por supuesto, una presión del driving pressure menos de 14. Sin embargo, hay otros factores que son supremamente importantes y que quizás son responsables por todos los ensayos clínicos negativos que resultaron hasta el momento, y es que el PEEP óptimo es aquel que se aplica al paciente que es reclutable. Y por eso, de manera muy intencional, empecé la charla con el ejemplo de reclutabilidad. Un paciente que no es reclutable resultará solamente en efectos adversos por un PEEP alto que ha sido inapropiadamente titulado. Entonces, es muy importante tener eso en mente. Y finalmente, nadie recibe una estrella o un premio o una medalla de oro por tener un PEEP titulado perfecto debido a las medidas perfectas que se hicieron con un balón esofágico o con un stress index, si el paciente termina con 3 presores y con colapso hemodinámico. Entonces el PEEP es el que nos ayuda a oxigenar, al mantener niveles de seguridad de la inspiración, pero también es aquel que nos permite el mejor desempeño hemodinámico del paciente. Y por supuesto, desde el punto de vista minimalista del poder mecánico, si podemos hacer todo esto, oxigenar, proteger y tener el mínimo compromiso hemodinámico con un PEEP de 10, pero también lo logramos con un PEEP de 8, entonces debemos escoger el PEEP de 8 desde el punto de vista de que entre el PEEP, si el PEEP es más bajo, la contribución al poder mecánico va a ser mucho menor. Entonces es un concepto minimalista de ventilación mecánica, a final de cuentas, el poder mecánico, y es usar los mínimos parámetros necesarios para llegar al objetivo terapéutico, que es oxigenar y ventilar al paciente, pero teniendo los parámetros mínimos nos ayuda a mantener un performance hemodinámico muy bueno y también un nivel de seguridad muy bueno. Y con esa diapositiva quiero terminar y dar las gracias a todos, y creo que tenemos un poco de tiempo para preguntas, si alguien tiene alguna pregunta. Sí.
Queremos llevar al paciente a la capacidad respiratoria para evitar la sobredistensión o la telestasis. En ambientes de recursos limitados como el nuestro, donde no tenemos tomografía por impedancia, en algunas ocasiones catéteres esofágicos no lo hay, solamente contamos en algunas ocasiones con eco y la titulación de PEEP guiada por driving, por distensibilidad estática y pues nada más, digamos que eso es lo que hay. ¿Cuál sería la recomendación que usted nos podría dar, tomando en cuenta esas limitaciones en cuanto a la monitorización y sobre todo en aquellos pacientes que tenemos cardiovasculares para evitar el compromiso hemodinámico a la titulación?
Sí, buenísima pregunta, muchísimas gracias. Es una pregunta que realmente ocurre muy frecuentemente en muchas de las charlas que damos, y es, si no tenemos una manera para medir el FRC, ¿cómo podemos hacer esta intuición? Y yo creo que si seguimos el concepto del driving pressure que mostré con los ejemplos y tratamos de identificar aquellos pacientes que son reclutables y que no, muy seguramente un PEEP bien titulado resulta en una ventilación que está muy cercana al nivel de FRC. Y de todas maneras el FRC es un poco, es una medida que es un target que se mueve debido a la relación que existe entre la pared torácica y el compromiso pulmonar. Pero yo creo que si sencillamente sigues el compromiso del driving pressure y tratas de resolver la pregunta de si el paciente es reclutable, no vas a tener ningún inconveniente en enviar una ventilación que está muy cercana al FRC.
Doctor Cortés, muchas gracias por su presentación. Quisiera preguntarle, dado que nos mostró algunas de las consideraciones que se pueden tener con la maniobra de PEEP decremental, ¿qué opinión le merece y si ha tenido alguna experiencia con la estrategia de índice de reclutamiento e insuflación del doctor Luchen, en el que se utiliza en una sola respiración el cambio del volumen tidal después de haber subido y bajado el PEEP?
Me parece estupenda. La razón por la cual no la incluí en esta presentación es básicamente porque en teoría funciona muy bien, pero funciona muy bien solamente si la resistencia inspiratoria es la misma que la resistencia expiratoria. Y el modelo del que hablas está diseñado con esa premisa. Pero realmente la resistencia inspiratoria y expiratoria cambia en el momento en que el paciente, el pulmón está enfermo, neumonías, SDRA, etc. Entonces, realmente las medidas que se toman en ese cálculo pueden ser erróneas. Entonces, yo pienso que se puede hacer ese cálculo, pero se deben tener en cuenta los otros parámetros, el comportamiento de la fase inspiratoria, el comportamiento del driving pressure a través del tiempo. Bueno, muchas gracias.
Muchísimas gracias al doctor Gustavo Andrés Cortés y continuamos, bueno, o antes de continuar, quiero recordarles, por si tienen más inquietudes y preguntas, que en los laterales del auditorio están pegados los códigos QR donde pueden registrar sus inquietudes y en próximos días a sus correos electrónicos directamente de los expertos recibirán las respuestas a sus dudas. Continuamos así entonces con la charla Manejo integrado de la falla respiratoria hipoxémica refractaria a cargo del doctor Richard Ockler.
Gracias. Thought you got rid of me. I don't have any disclosures for this talk. I think hopefully we'll try and integrate a couple of the concepts we've talked about this morning here, talking about refractory hypoxemia. I think the first objective we're going to have is to actually identify refractory hypoxemia. I don't have the time to show you some of our old data from Mayo, but suffice it to say that we have been historically very poor at determining patients that are truly in refractory hypoxemia, and it's important for several different reasons. I'm going to try to hope to convince you today that by taking a kind of standardized approach, not necessarily a protocolized approach, but just a standardized approach to how you approach these patients, that you may identify reversible causes and actually find that the patient is not in refractory hypoxemia. Those patients are actually fairly rare. I would say on average, 5 to 10% at most of the patients you might see. I can tell you in our ICUs at the Mayo Clinic, there are about 2% of the patients that we see are in true refractory hypoxemia after we proceed with a number of different measures that Dr. Cortez just nicely outlined, and PEEP titrations and other treatments for the underlying causes of these potential issues. And also realizing that we ourselves may be causing the refractory hypoxemia by our choices of ventilator setting. Again, I don't want to harp on it, but there are some places where guidelines are just missing or may not apply. And so in those cases, we really need to be able to move on and utilize our fundamental knowledge in physiology and the cardiopulmonary relationships to kind of guide us where the guidelines cannot. So those are the technical or academic questions. I guess the real questions are, does my patient really have refractory hypoxemia? How much of this is art and how much is science? There isn't a really good, solid international guideline here. And finally, if you are in true refractory hypoxemia, do all roads really lead to extracorporeal support? This is actually one of our cardiac surgery anesthesiologist car's license plate. It's kind of embarrassing. I will assume that all of you are aware of the newest guidelines for ARDS. There are two competing guidelines. We had discussed this a little bit with the trainees yesterday. I'm just going to leave them here. There are the references. The QR codes can be scanned so that you can get those references downloaded for yourselves. But I will not go in depth into the actual ARDS guidelines. So again, the first issue is to really define the problem. And so there are a couple of things that we need to address. I think the easiest one to define is severe. I think the most agreement on what severe hypoxemia means is expounded depending on whether you're in the pediatric ward, the neonatal ward, the adult ward. We have different ways of measuring that. So PF ratio is usually less than, you can see some of the numbers here. An SF ratio has become a little bit more popular in some places around the world. And then the oxygenation index is also one that you may have seen and used. So we can get pretty good objective grading of the severity of the hypoxemia. Where it becomes a little bit more nuanced is in what refractory means. And so I think we all have a little bit of a different idea, but depending on the numbers, we still get to a point where we all have about the same concept of what it is. And so here are several different surveys and papers that have listed different ways of defining what is refractory, but ostensibly it's going to be some treatments to intervene and try and improve that oxygenation and see how they respond. It's really important, though, to define this patient as being in refractory hypoxemia rather than just severe ARDS, because we know how statistically refractory hypoxemia has a much higher mortality than even the severest of severe ARDS. And you can see the numbers there. So we're talking over 50%, up to 60, 65% of patients with true refractory hypoxemia across, several different studies potentially dying of this disease. So we said, well, we can't treat something unless we really identify it. And so if any of you are in the military, sometimes they use these types of terms. So I would call this a swag, a scientific wild ass guess of what the best definition of refractory hypoxemia is. And so we had a consensus of experts at our institution come up and try and put together from different guidelines and different understandings. And so this is what we would call a patient in refractory hypoxemia, someone who can't oxygenate despite a high oxygen delivery, despite optimizing the mechanics, the PEEP, et cetera, and that this is prolonged for at least 12 to 24 hours. So I in the last talk, I spoke a little bit about the mode wars. I guess my issue here is the further debate on what mode I might choose or what ventilator settings I might choose. It's not about me. It's about the patient and my team. Mechanical ventilation just doesn't happen during the day or on the weekdays, and then, we wait till Monday to change this. I would say, mechanical ventilation and critical care as a whole, as you all realize, is a multidisciplinary, integrated team sport. And the best mode is the mode, and the best settings and the best approach is that which your whole team is going to have a shared mental model of. This sounds almost like lip service or philosophy, but it really is very important that all of your practitioners, whether they be the respiratory therapists, the physicians, the nurses, you all have the same idea and the same shared mental model of what we're trying to accomplish with that patient at the bedside. So this is our what I would call refractory hypoxemia protocol. I always hesitate to use the word protocol because of the fact I don't want to tell you exactly what PEEP to set or what tidal volume to set. It's more a stepwise approach to the patient just to make sure that we touch upon all of the different aspects that we need to assess that could be causing this patient's hypoxemia and their illness in general. And so you can download, this is available online. We've tweaked it a little bit. We've added some things. I just want to point out how we start. So as we intubate the patient, we'll usually choose a tidal volume, say 6 cc's per kg, and that's just to start and get some measurements, and then we move on through the table from there. The other point I want to highlight is we want to identify these people rapidly, and so you see that circle up there at the top of complete within 30 minutes of intubation. I would argue you could do that in 10 minutes, and your goal should be to do this as quickly as possible. So again, a little bit more philosophy, a shared mental model and why it's so important. I can tell you how we do it at the Mayo Clinic in Rochester, Minnesota. We're very multidisciplinary. So I asked throughout the conference here, how and who sets your ventilators? In Rochester, although the physicians and the respiratory therapists are primary, we do have the integrated team looking at the ventilator. They may not specifically change and turn the knobs and the buttons, but they would have input. So an example of that is you see the physical therapy, occupational therapy, PTOT. They may sit the patient or walk the patient and note to us what the strength is and say, hey, maybe today is the day to try a spontaneous breathing trial. And so there's just an input from all members of that multidisciplinary team. The other key is their frequent touch points. So we have 3 teams a day, and at least 2, if not 3 consultants who may see a patient in the ICU. And then our respiratory care staff has a mandate to see every mechanical ventilated patient at least every 4 hours. And I can tell you that that actually happens more on probably the 1 to 2 hour time point. And so these patients, because these disease processes are very dynamic, they're being seen and reassessed every few hours. And then we have, and we try to take advantage, I know AI is the hot thing to talk about. We have what I would call electronic sniffers to augment and surveil those patients continuously and non-fatigably. And so this is just it's a test sample. We're developing this with a certain ventilator company that we use, is a ventilator dashboard where I can see all of the patients in our ICUs. And what I would point out is I can sit in a standardized area, or the respiratory therapist can have this in their back room with alerts and point out different goals and triggers. So we're on a standard protocol versus an ARDS protocol. I see the trend in the oxygenation. I see some of the driving pressure and other parameters, and then I get warnings that can be paged out to email or our pages say, hey, in this patient, the driving pressure is high. You better go see them. And they could, even before they get to the bedside, look up the waveforms and see what's going on there. So this is coming down the pike, but again, it's a little bit like detecting septic shock or sepsis early on a patient on the floor. This we kind of view as an early warning detector of problems with our ventilation strategy. So what are our general goals to treat ARDS, and more importantly, for this talk, refractory hypoxemia? I think it's this integrated approach that you've been hearing about this morning. So we're obviously interested in the lungs, and I think we've focused for the past 20, 25 years of approach to ARDS only on the, really focused mostly on the lung side of things, with, I don't want to say forgetting about the heart, but just saying, well, the settings are good enough that our blood pressure or some of the other responses seem to be okay, rather than really focusing on the health of the heart at the same time we're setting the lung. And then it's always important, I would argue, that 50% of mechanical ventilation is a mind game. It's psychiatry. You want that patient to feel like they're getting enough air, whether that's you put a little bit of an inspiratory pause on that fires the Herring-Breuer reflexes, and then you have all sorts of feedback mechanisms that go to that apneustic center and the pons and the medulla and say, hey, I'm getting enough air, even if they're not. And so that's what I mean by either normalize that O2 and pH if you can, and if you can't, utilize some other tricks that might at least make the patient feel like they're getting enough air. And that can help you with synchrony and protection against villi in some instances. So what are key components of a refractory hypoxemia strategy in 2024? I delineate here core, adjuncts, and rescue therapies based on some of the literature, and I'm going to give you my opinion as we move forward. And I think the opinion of a number of folks in our group about maybe those labels aren't so important, and maybe they even need to be shuffled around a little bit. But notice the core is what we're talking about, is really accomplishing this quickly, this at least the safe ventilator setting of your targeting of driving pressure or mechanical power, whatever it is. Get that done quickly. There are other adjuncts like conservative fluid strategies. We won't really focus on that today, but it's just good best practice standard of care. The question is, though, once we get past that ventilator setting, is we have a lot of different adjuncts and other therapies, but in what order do we do this? And so a lot of this is where your knowledge of applied physiology, the personalization and individualization of your approach to that patient may tell you, okay, we're going to go prone a little bit earlier, or, in this patient, maybe we need to recruit them because of their size and they had a long apneic time, et cetera, et cetera. So let me just give you a brief case, and we'll just start with, let's say, a gentleman with ARDS, presented 5 days of fevers, chills, rigors, kind of your standard infectious pneumonia leading to ARDS, initially admitted to the pulmonary hospital service, continued to worsen, went to high flow, some non-invasive ventilation, unfortunately continues to decompensate, moves to the ICU. This is the chest x-ray. And so proceeded to a CT at some point, and you can see what looks to be what concerning for obviously ARDS with a high oxygen requirement, bilateral infiltrates. And so I would call this a bread and butter case. And the reason I say this, and the standard case, this is kind of the patient that all of the guidelines, all of our data cover, right? So this is early ARDS. This is the data we have for driving pressure, for neuromuscular blockade, for all of those things apply probably to this patient in that first early phase of ARDS, the inflammatory phase before we may be heading towards fibroproliferative stage and late stage ARDS and pulmonary fibrosis and scarring. And I just bring that up because maybe I would have a little bit different approach if this was a late stage or a patient with long-standing pulmonary fibrosis, now an exacerbation of IPF, and there may be some difference to the mechanics in what I'm trying to do and what I'm trying to prevent. So this is what I would propose to you would be my immediate post-intubation checklist. And this is what we would do on most patients when we intubate them in the Mayo Clinic. We usually will use something like propofol, succinylcholine, rocuronium, some kind of induction agent and a paralytic that gives you time that your patient will be passive once intubated. And that's really your time to take advantage of this passive period to get not only your initial vent settings dialed in, but do that respiratory mechanics assessment, whether it's your ventilator that can do a static pressure volume curve, or you do some of the maneuvers Dr. Cortez Puentes was just speaking about, or recruitments and titrations, but get some idea of what the compliance of your lung is, where your PEEP might need to be, get your driving pressure, everything dialed in quickly. And again, I'm being generous here. I bet you could do this in 5 to 10 minutes. I'm saying, let's finish that in 15 minutes if we can. Because once we're there, this is really what I want to know. And I won't belabor the point of the hysteresis that Dr. Cortez just talked about. But at the end of that 15 minutes, I have a good gestalt or idea of what kind of patient I'm dealing with. Is it the curve on the left that is a fairly compliant lung and potentially has some recruitability? Or am I dealing with something that's a pretty stiff lung over here and doesn't look to be recruitable? And that's going to really inform my decision-making going forward. The other thing I'm interested in when I have those curves is to just take a look at my waveforms on the ventilator. So when I'll call this open space, what I'm really talking about is how much time I have in between breaths to make changes. And what I mean by that is if we're looking here at this here, patient, you see the flow coming back to baseline. I have probably a good second of what I would call open space or time in between breaths that could lead me to potentially put on an inspiratory pause or change my flow characteristics, et cetera, et cetera. Whereas, in these patients on the right and on the bottom, there's very little time to add on any kind of other changes or slow down my flow or change my flow profile or have an inspiratory pause without leading to breath stacking. So I think that the analysis of that pressure volume curve and looking at your waveforms will give you a very quick estimate of, is my day going to be awful, or am I going to have a pretty easy day with this patient, dialing them in and getting them set? And so I should just make a comment here again to reiterate, this would be someone I would say is going to have a low probability of refractory hypoxemia. I have plenty of room to make some adjustments. The patient looks like the lung will be responsive to my adjustments. And so hopefully by optimizing my PEEP, getting my respiratory rate and my minute volume set, we'll have a pretty good gas exchange. Now, this one, I say, oh boy, there goes my morning if I've just intubated this patient, because this one's going to be a little bit tougher, right? The lung is very stiff. Driving pressure is probably already high. I don't have a lot of room to change things. You see on that waveform, I actually have a little bit of an inspiratory pause on, is why you see a plateau. So I might maybe remove that. But it certainly is more concerning if I see this patient right out of the gate. And I think I put a summary of those things here, But what am I doing in that free space or that room to work? Well, if I'm really needing to address hypoxemia over the hypercapnia, there are other things beyond PEEP that I can do to improve my oxygenation, because really what I'm trying to do is increase my mean airway pressure, right? You remember Fick's law of diffusion, driving that oxygen across the membrane. So if I come to the bedside, my mean airway pressure is 10, my oxygen is not going to go up unless that number reads 11, 12, 13, 14. And so to do that, I can do some of these interventions I list here. Whereas hypercapnia is really the opposite, right? I actually need to increase my minute volume, increase my respiratory rate. And so at some point in a very sick lung, these two things become mutually exclusive. And of course is why we oftentimes have to tolerate some hypercapnia, and we call that permissive hypercapnia, of course. So back to our patient, let's say we've optimized this patient as best we can. You see some of the parameters there, still on a very high oxygen requirement. SAT is low, but it's maybe acceptable. But again, at an FiO2 of 0.8, our CO2 is high, our pH is becoming concerning as well. So what's my next step? Well, if we go back to these key components of the refractory hypoxemia strategy, and again, not maybe knowing which one you would want to apply first, I guess my first argument is, what are these are core, what are these are adjuncts, and which of these are, a rescue therapy? I might propose something more like this, adjuncts versus rescue therapies. In my view, in 2024, really the rescue strategy is going to be extracorporeal support. All of these other processes that seem to be very advanced or very rarely used in 2000 in that ARMA trial, 1999, nowadays have become somewhat common, especially after the pandemic and COVID. And so I would argue lots of these are just even core values. And so I would actually change this kind of core intervention to refractory hypoxemia. This is how I would look at my stepwise fashion here. And so you see I have highlighted next is potentially neuromuscular blockade. And I'd love to have discussion on this because of the fact that there were several different trials that I'm sure you're aware of. That first trial, the Papazian trial, that looked at neuromuscular blockade in early ARDS in the first 48 hours, and a continuous infusion of cisatracurium suggested that there was going to be a mortality benefit. And that prompted then later on the Rose trial, which then was a negative study. I guess let me just start by saying this is why I use paralysis. And so sometimes it's because I have chest wall stiffness that could be due to muscle rigidity, and I would like to take that away to improve some of the chest wall mechanics. Another one we saw during COVID is fentanyl. So fentanyl can cause something in high doses. The anesthesiologists in the group have probably seen this wooden chest syndrome where you get this contraction of the muscles with high doses of fentanyl that can only be improved with paralysis. The next one is my resting VO2. So oxygen consumption, anywhere between 10 to 15% of resting oxygen consumption is due to inert muscle activity. And so if I'm delivering all the oxygen I can, and I'm taking away or clearing all the CO2 I can, then the only other thing I have left is, well, can I reduce the need for oxygen or the oxygen consumption, which will also reduce the CO2 or the VCO2, right? The CO2 production. And so those are the two main reasons. And frankly, I probably would put number 2 even before number 1. And I purposefully put number 3 far down the chart. And I bring that up because at least during the pandemic, and even with some of our newer nurses now, we often have them calling us and saying, hey, the patient is asynchronous, I need some paralytic. And I would argue I would make other interventions before I would move to a paralytic just because of ventilator asynchrony. You may need it ultimately, but please look at other interventions before that. And so again, talking about Rose versus the Acuresis trial, I think, again, I don't like the fact that they just randomized all patients to neuromuscular blockade. Again, I think you need to choose this intervention based on physiology. And so the previous slide I showed you are the types of patients that I would use neuromuscular blockade on. But I wouldn't just give it to every patient in early ARDS because, well, they don't all need it, and neuromuscular blockade is not treating the underlying cause. So if we're not worried about refractory hypoxemia and I'm doing fairly well, well, unless I was going to something like prone positioning where I'm worried about safety, I probably wouldn't, heavily sedate and prone the patient. But that's just an aside. I also, and it's a talk on itself, the comparison between Accurasis and Rose. I would argue to you, if you read the Rose trial, and especially the supplements, they excluded all patients that were on neuromuscular blockade already in the first 12 to 24 hours. And I would argue to you that those are the patients that I was just describing to you that needed the paralytic, and they were excluded from the trial. So that's my commentary on neuromuscular blockade. What next? And I think, with COVID, we got to be much more, I would say, comfortable with proning patients. And that may be something from the United States. I think outside of the United States, people were very aware and utilized proning and different positional changes much more to their advantage than we had previously. And so there are a number of things we can talk about proning. Here's an obese patient in our ICU. That happens to be me. But the question here is, you all know the data. Prosiva was the one that really sparked or confirmed the thought process that had been going on for years, especially in French studies, of signals towards mortality. Prosiva came along and showed a significant improvement in mortality in proning in early severe ARDS, and that was, back in about 2013. This was confirmed by multiple studies in COVID. I just put 2 or 3 of them here, but there were several more after that. I think the scope of proning and self-proning in non-invasive patients probably beyond the scope of this talk, but that obviously is another potential use of the prone position. How does it work? Again, you probably are aware of most of these physiologic changes. What we're really trying to do is not only improve some of the lung recruitment or recruiting areas that may not be recruited in the supine position, and then homogenize that lung. So taking away stress concentrations, basically getting us to a West Zone 2 physiology, right? So the best type of VQ matching we can for the most areas of that lung. And so just showing several studies, I think this is a nice one because in the supine position, we're really worried about those dorsal areas near the diaphragm that really get de-recruited. And you can see with prone positioning, this is in the supine position, that the distribution of tidal volume really improves with proning to those areas, which, as you know, are kind of a West Zone 3, and they're probably changing to either West Zone 3 or staying at West Zone 3 or going to West Zone 2. And so you're getting a better VQ matching by recruiting those areas. Other adjunctive things, you're eliminating some of the compression on the lungs by the heart, how much that really contributes. But again, it's offloading some of the mediastinum from the lung. And then just, airways drain best in the prone position. And you've probably seen this in someone who's got either bad pneumonia or even patients in heart failure. Sometimes you'll just see that pulmonary edema start flowing out into the ET tube if you're intubated. So recruitment maneuvers, I guess in select cases, Dr. Cortez talked about some of the strategies on a recruitment maneuver. I would note, and he also talked to you about how to do a recruitment maneuver. I would just point out from these papers, I find it interesting. So you remember the most recent trial saying that, well, recruitment maneuvers are bad from Dr. Amato. I would point out that Dr. Amato has many of the papers on the physiology around recruitment maneuvers. And this one from back in 2006 really showed, and I think Dr. Cortez emphasized this, is the opening pressures and how much pressure you really need to open most of the lung. And you'll notice it's probably 35 to 40 centimeters of water. And then Dr. Arnall and others, I think the Arnall study is the one that really confirmed that there's no need to do a recruitment maneuver over about 10 seconds or so. In fact, if you do a recruitment maneuver for more than about 10 seconds, really the only thing you see after that is hemodynamic effects and potentially collapse. And so from these kinds of data, the old 40 seconds and 40 centimeters of pressure and those types of strategies gone away. And what the Amato study I was referencing actually performed inflations to as high as 60 centimeters of water for minutes at a time, and then actually had to stop due to several cardiac arrests. And so I would argue to you that was not the proper strategy to do a recruitment maneuver. I don't advocate for doing recruitment maneuvers in every patient necessarily, but if you were going to do a recruitment maneuver and then titrate your PEEP, by the way, Dr. Cortez was showing you, I think I would do a recruitment maneuver for 35 to 40 centimeters of water for 8 to 10 seconds, no more, and move on from there. And in fact, a lot of the modern ventilators that have recruitment maneuvers built into them utilize this type of a strategy. So, from there, we then are getting into things that are getting a little bit more advanced or off-label, or getting into the realm of things that Dr. Mankad was addressing, which are cardiopulmonary mechanics and assessments. And I would argue that the Swan-Ganz catheter, or pulmonary artery catheter, esophageal manometry, EIT, these are all excellent tools. And sometimes when we are worried about the tool causing harm, because I know we've gotten away from using PA catheters, I would argue, and what I'm trying to show in this picture is sometimes it's the archer and not the arrow. And that if we understand what we're measuring, these are very helpful adjuncts. And I think Dr. Cortez and Dr. Mankad earlier showed you why, and I just reiterate this now for the third time, some of this airspace fixation error. And so what I would argue, and you've already seen this strategy, I would argue two things. I'm curious if anyone in the audience uses airway pressure release ventilation or any of the inverse ratio modes that stay high very long. I would worry in certain cases, so Dr. Cortez talked about patients that are not recruitable. Well, then I would argue, then why are we trying to have such a high sustained mean airway pressure if that lung is not recruitable? And then here, because we're pushing ourselves well up towards almost TLC in those types of strategies that will really impair the Q portion of the VQ matching. And so I depict this a little bit differently just to maybe drive the point home to you in a different way. I think all of our ventilator strategies in the past 20 to 30 years have focused over here on the left side, right? We get ourselves a PV curve. We want to dial in here to that kind of sweet spot where we do very little work for a very big volume gain and avoiding atelectasis or barotrauma, and we completely forget about this whole relationship. And so if this is a patient that's a PEEP responder and I'm ventilating down in this region, well, if I turn the PEEP up, not only do I now move into a better region from the aeration side, but I've also moved closer to FRC and now am perfusing that better. So this is your classic PEEP responder. It's the way it's supposed to work. But I think what we've been trying to point out to you is oftentimes you may start at this scenario, and we don't know unless you have a PA catheter in, you're doing echo measurements. Dr. Mankad and I are working on some strain, potentially some measurements moving forward, looking at RV strain to set PEEP. But I don't know where I am on that curve on the right side of the screen until I start doing some maneuvers. And so if I turn the PEEP up in this case, I may be ventilating fine, but I'm not actually getting any kind of gas exchange because I'm not really perfusing those areas as well. And oftentimes I may come into a room and I see the PEEP is at 18 and they're really struggling. They're hypoxic, patient's not doing well. And all I do is turn the PEEP down. People say, well, how did you improve that patient? Well, I just turned the PEEP down. It's too high. And again, you're doing that with measurements and changes, but it's an important concept. And so I would just combine this with esophageal manometry because we were one of the studies, one of the study centers in this EP-Vent2 trial that compared esophageal manometry and the PEEP tables. And I think Dr. Cortez showed you EP-Vent1 where there was a signal towards benefit of using the esophageal manometry. What we found is whether you use the high PEEP ARDS table, ARDSNet table, or the esophageal balloon, they come out very close. And I think it leads to excessive PEEP because, again, it's focused just on the airspace side of things. It also is difficult because that balloon will continue to read those high PEEPs and suggest those high PEEPs even as the lung starts to improve, and it leads to difficulty sometimes weaning the patient down. And so I think there are just some issues with the esophageal manometry that as long as you're aware of them, I think it's a good tool in specific cases, but certain times it can be an issue. Quick points on cardiopulmonary interactions that Dr. Mankat didn't point out. I think the one I really want to focus on is the shunting, and especially in some of your congenital patients. So if a patient usually is a blue patient that lives at a SAT of 85%, you're not going to get those patients to 95%. So please don't try to get them to 95%. You have to have kind of a sense of where they are at baseline. The other issue is in some congenital patients. So patients like a failing Fontan, or the congenital patients that don't have a right heart pump, PEEP is highly deleterious. And those patients also have a lot of collaterals for shunting. And so if you turn the PEEP up, they get worse. The blood pressure goes down. Then people put pressors on. The pressor actually causes more shunting, and the situation gets worse and worse and worse. And we've published several cases where we've actually extubated to room air a patient that was on 100% FiO2 and a PEEP of 10 that was a Fontan, that as soon as we removed the positive pressure, actually almost everything sorted itself out. And within about 6 hours, the patient was actually on room air. So just be aware again of those things. The other thing I point out here is in some of those patients that are chronically hypoxic, their hemoglobin may be 20. So now if you've admitted them with a GI bleed and their hemoglobin is 12, and that's still in the normal range, you might ask yourself, well, for this patient, is the carrying capacity appropriate? Or do I actually need to treat and transfuse them well above where you would do your normal patients? I don't think nitric oxide, I think most of you know how nitric oxide works, and prostaglandins and vasodilation, and so I won't belabor that. The summary, I think, is in 2024, the real indications for our patients with pre-existing pulmonary hypertension do have a mortality benefit. Pre-existing, not hypoxic vasoconstriction from the acute ARDS, unless you're having right heart strain that could be leading to potential failure. Post-cardiac surgery is where almost all of the data comes from. There's excellent data prevent RV failure in the post-operative setting, and so that's where we have based a number of these guides on. And then as a true rescue therapy, so if this patient is really doing poorly, I want to preserve not only the heart function, but maybe bump my SAT up for a 2 or 3% points to get me somewhere, to either transplant, to ECMO to transplant. If it's a younger patient that meets the criteria, then I might use it in those situations as well. I think all the others, some of it is conjecture, but again, if you're doing your right heart assessments and you're really worried that even with vent setting changes, you can't offload that RV, then I would advocate for the use of one of the pulmonary vasodilators. And I'll finish with this, which is what I would call a very common cause of refractory hypoxemia at our institution, and I would call this iatrogenic refractory hypoxemia. So this is the case I told you about when we started, right? The one I'm always concerned about, a very stiff lung. As Dr. Cortez was talking about recruitable versus non-recruitable, is a non-recruitable patient. Their oxygen is low, their CO2 is high. Invariably, a fellow or a resident comes to me and says, the driving pressure is 25. What are we going to do? We need to drop the tidal volume. And as you all know, dead space in an average patient, 2 cc's per kg, somewhere in that range, 150 cc's. In a significant fibrotic ARDS patient, your dead space may be 4 or 5 cc's per kg. So I keep dropping the tidal volume down. This is kind of a vicious death spiral. There has to be a better way. And so what you see is, where the patient's hypercapnic, hypoxemia, can't make any progress. Invariably, this patient gets a call for ECMO. And in her case, they would say, it's a late stage ARDS, not a transplant candidate. We're not putting them on ECMO. But the question is, and I think Dr. Cortez covered this, is, PEEP, what is the use of PEEP? Is there use for PEEP in this patient? Why are we on 15 of PEEP in a non-recruitable lung that's causing our driving pressure to be even excessively higher and potentially impairing our perfusion? And then, the question is, as I point out here, is with the tidal volume and the driving pressure, we're not going to be able to achieve the targets in these patients. And let's be honest, even if this patient developed a pneumothorax with such a stiff lung, it probably wouldn't even collapse. So you have to take these risks and benefits and say, you know what? I think we're going to, number one, drop our PEEP. There's no point in the PEEP because the lung is not recruitable. And then number two, we may need to liberalize the tidal volume a little bit. And so I'll stop with that. I just point out this case, which is another one that can sometimes be a problem. And I think Dr. Lim will talk about a little bit about obstructive lung disease, and also a good discussion for us later on if you'd like to talk after the actual didactics are done. So my take home again, I reinforce driving pressure will get you most of the way you need to go, but neuromuscular blockade, prone positioning, even a recruitment maneuver in the appropriate patients. And then don't forget that perfusion of the lung. It's really important. And if you go through all of these things quickly within that first 30 minutes, even all of these interventions you may get through within an hour or two, but definitely by 6 hours. If you've identified that none of these things are helping, then get your ECMO people or extracorporeal support people involved early, or potentially look for a transfer if you have to go somewhere else. So I'll stop with that.
Bueno, muchísimas gracias. Escuchamos al doctor Richard Ockler y continuamos con la intervención del doctor Kaiser Lim, que nuevamente nos acompaña hoy en el cierre de esta jornada, dando continuidad a la actualización del abordaje médico integral de la falla respiratoria aguda. Desarrollará el tema de farmacología y manejo ventilatorio de la enfermedad obstructiva severa.
Thank you. My topic's relatively easier. And so first thing we'll do is I entitled this A Tale of Pressure, Volume, Flow Rate, and Breathing Frequency. And I thought, it'll be nice for us to review the physiology and pathophysiology that would lead to problems when we are trying to resuscitate patients with obstructive lung disease. So we'll touch on functional residual capacity. This is turning into a very key concept, isn't it? You've heard it from Dr. Mancad, Dr. Cortez, and Dr. Ockler. And we always think about functional residual capacity as compartmentalization of the lung volumes, but it does have a significant physiological role. We'll talk about closing volume and why the lungs does not have atelectasis normally. We'll be talking about the RC time compliance from the expiratory point of view, in contrast to what you've heard before, which is all inspiratory, increasing the inspiratory time in order to fill the alveoli. Finally, we'll talk about air trapping, the resulting dynamic air hyperinflation, and then what the rise in intrathoracic pressure does to the patient, which Dr. Mancad very nicely discussed today. So one of the things to highlight is that end expiratory lung volume is not always the same as FRC. And FRC is actually, as mentioned before, a dynamic state wherein the chest wall expansion equals that of the elastic recoil. So if you ever go to an autopsy, you split open the sternum. First thing that happens is the chest wall expands. And so if you break the vacuum seal between the chest wall and the lung, like you have a pleural effusion, you will find out that the chest wall goes up maybe 60%. The atelectasis is like around 40%. So at FRC, this is a dynamic balance, and that the intraalveolar pressure at FRC is 0. Now, if you look at your flow volume curve, effort can only get you so far. So if you look at curves A, B, and C, you will see that at some point, all three of these curves end up in the effort-independent zone, wherein the amount of air coming out is not going to change no matter how strongly you try to blow out. And the way you imagine this is in terms of this graph. So you have your tidal breath. Normally you stop at functional residual capacity. You take a deep breath and then you blow out. And this is where you start hitting your effort independent zone. We call this the closing volume. And this, including the residual volume, is called the closing capacity. Serves a very important function. It prevents atelectasis during regular respiration. So think about this cartoon. First thing that happens, you blow out. And your elastic recoil is added to your transpleural pressure, which now becomes positive relative to your mouth. So you have a forward momentum, and that's how air goes out. But the airways are collapsible entities. They are subject to the same pleural pressure. And as long as your pleural pressure is less than your alveolar pressure, you have a resisting pressure laterally that keeps the airways open. However, when you go downstream, closer to the big airways, it equalizes, and that's where your equal pressure point is. This is normal. Everybody has the equal pressure point. And so once you hit the equal pressure point, it becomes effort independent, because this is how the body protects itself from having atelectasis during normal breath. Now, what happens in diseased lungs or diseased airways? It moves towards the alveoli. It collapses closer to the alveoli so that the equal pressure point is reached earlier. And that is what causes the air trapping. Now, here is what we call a CT scan total airway count in asthma. The gray will show you a normal, GINA 1, 2, 3, not very severe, GINA 4 and GINA 5, which is a progressive worsening of airway disease. You will notice that there's pruning. There's pruning of the airways, thickening of the airways. Thickening has a very pernicious effect because the thickening comes from many mechanisms. And you also have mucus plugging, to the point that here's a 16-year-old boy who thought he'd live forever. You've got mucus plug. You have loss of mucosal folding. Now, this is an important concept. The accordion-like mucosal folding prevents the airway from collapsing completely. When you lose that, because your basement membrane is thickened, it can collapse a lot easier. Then you have the airway wall thickening, and then you have the bronchospasm. So let me walk you through a prelude to respiratory failure. You get a rhinovirus infection. Your airways become more inflamed. You have more inflammation. You increase your respiratory rate because it's harder to take deeper breaths. So what you do initially is you increase your respiratory rate. What happens? You decrease your expiratory time. You get sicker, and then you start trapping air. What happens is then you have increased intrathoracic pressure, leading to occult PEEP, even in spontaneous breathing. And what it does is it causes fatigue, increases your intrathoracic pressure, reduces your venous return, and decreases your cardiac transmural pressure. So imagine this. You start at FRC. You have progressive increase so that your end tidal and expiratory is no longer equal to FRC. And what you have shown in this flow volume loop, look at where it ends. This is technically where your end expiratory volume is. This now starts hitting the flow limitation, and you are now moving it to the left. So this is the composite view, and this is what dynamic air trapping shows with increased minute ventilation. And so your dynamic hyperinflation occurs. And so that's why our patients are getting into trouble. What happens with obstruction is that we have to go back to our physiology, and we realize that the alveolar compliance is meeting the airway resistance. So the resistance compliance multiplied together is your time constant. And 1 tau is the amount of time it takes to empty 63% of the alveoli. So imagine your airways and your alveoli, that's a mixture of low compliance and high resistance, normal resistance and normal compliance. You essentially have over 2,000 bronchioles that have a compliance and resistance product that is different from each other. And so you will have different tau, different time wherein you empty out by 63%. And this is what it looks like by xenon MRI functional scan. You see that ventilation is now so heterogeneous. Some of it is mucus plugging, some of it is because of the hyperinflation. And herein lies the answer. You need to bring your end expiratory pressure closer to FRC by eliminating your dynamic hyperinflation. And so you play with your tau. And what does that mean? You have to increase your expiratory time. And to increase the expiratory time, you have to decrease the breath size, of breath frequency. That means that you have to deliver more flow in a shortened amount of time. It also means that you have to pick in a volume respirator a decelerating mode so that you deliver the initial volume to the large airway, and then it will slowly drift to the small airways because of the inspiratory RC time constant. And a smaller tidal volume is important because then you're not putting too much pressure on the system. I hope that helps people imagine the ventilatory approach in a very logical fashion. So first thing we will meet is non-invasive positive pressure ventilation. Because if you can avoid intubation, your patients will do much better. But the problem with non-invasive ventilation is that it's very labor intensive. On the average, it takes an hour to 2.5 for the RT to work with the patient. So from the get-go, if your patient is presenting late and you don't have the resources, NIPPV is going to be a challenge from the get-go. If you delay intubation, your patients actually get hurt. Always be prepared. At some point, you're going to develop this gestalt. Patient walks in, you look at their breathing, they're hardly moving air. You will know whether you should try NIPPV or not. And of course, I always say, if you have a patient who looks like somebody from Duck Dynasty with the hair and the face and everything, you're never going to get a mask to fit. And so some of these things you will learn by gestalt. You can still try, but just know that everything is dependent on the mask fitting. At Mayo, we have a Philips V60, and then also we can use a Hamilton G5. I tend to advise people to think of longitudinal care. If the patient gets intubated in the emergency department, going to the ICU, if what you have is a machine that can be carried forward that gives enough flow, can be converted to invasive mechanical ventilation, you might be better off doing the full ventilator. The advantage of the V60 is that it has mechanism to compensate for airflow. But then this is a very device dependent. And the question is, would you still be using the same device when you're in the ICU? We always talk about BiPAP rather than CPAP because you need that driving pressure to help your patient because you have somebody who's already tired. You have PEEP, you normally dial in 75% of their occult PEEP to stent airway open to decrease auto PEEP, and you want to increase their expiratory time. First thing that happens to patient when they're doing well is they fall asleep. First sign of acceptance of NIPPV is they settle down and they fall asleep. Sometimes you may have to sedate them, give them a hypnotic, calm them down because they come in with adrenalines, albuterol around the clock. You're already looking at tachycardic stressed out person. So if it doesn't work and you do an invasive mechanical ventilation, we have to do it properly in order not to hurt the patient. So here's just a reminder of Ohm's law, wherein flow is due to change in your driving pressure over resistance. Since this is an obstructive lung disease talk, we are going to concentrate on the resistance. So the endotracheal tube size is very important. Your airways are very important. It's constantly going to be plugged up by mucus. You have to be aware of that. It finally has to push open your parenchyma for gas exchange, and then you encounter problems with chest wall and abdominal pressure, especially in patients who are obese, patients who are pregnant, patients who have large abdominal girth, like in cirrhosis or whatnot. So here's a classic John Marini paper wherein you are taught to play with the expiratory port. You put the patient on an expiratory hold, you plug it, and then you'll see the pressure go up. It'll be nice if you see this lack of emptying, in which case you don't have to play with the expiratory port. So this is the way you imagine this. Here's the pressure time curve on a patient you just put on a ventilator. This is your peak inspiratory pressure. That means that this is the pressure required to push through everything we just showed you. You put an expiratory pause in this, and you get your plateau. And that's going to determine the safety that you would want. The difference between the two is your resistance. Now, if you apply the expiratory pause, sometimes you may find out that the pressure goes up, and that's actually your auto PEEP. That's your occult PEEP. And so if you think about it from the patient's point of view, the machine, the patient's actually working harder in order to trigger the machine because it's a -7. You have an occult PEEP of 5. That's why when you also dial in the PEEP, aside from the concept of stenting open the airways, it allows the machine that measures the pressure from the mouth. It doesn't go into the lung. The ability to see the change and drop in pressure, and this promotes ventilator synchrony. Now, assist control, initially, volume control ventilation, you pick a tidal volume, respiratory rate, you optimize the inspiratory time, you pick an I to E ratio of 1:4, and a PEEP that's 75% of your auto PEEP. And then you do whatever FiO2 is necessary to maintain it at around above 90%. So let's do this exercise. This is a great exercise for trainees because you can change parameters and see what the expectations are. So at 6 ml per kilogram in a 70 kilogram person, you're going to be looking at pushing 420 cc's with a respiratory rate of 14, 1:4 ratio. That means you have 4 seconds per cycle. Breaks down to 0.85 seconds of inspiratory time. And if you look at the inspiratory flow rate per breath to deliver this much, you're looking at 30 liters, and your tidal your minute ventilation is going to be 5.9 liters. Now, if you were facing high peak inspiratory pressure, you could potentially change the combination by decreasing the breath frequency, in which case you now have 6 seconds of cycle time, 1.2 seconds of inspiratory time, and the inspiratory flow rate goes down to 21. Of course, your minute ventilation is going to drop. And that's when we start talking about permissive hypercapnia. And you have to be prepared for that. We monitor it frequently because you will find out in asthma, corticosteroids take 4 to 6 hours to kick in. If there's a lot of inflammation, it'll take a few days. You want to make sure that the patient is safe. You're not causing more trouble, like what Dr. Oakler has alluded to. And if necessary, if the patient is anxious fighting the vent, you may end up having to sedate and paralyze them. Hopefully not frequently, but it's sometimes inevitable. If you've done everything right and the goddamn alarm keeps going off, just turn it off. It's gonna cause more stress on your team than anything else. But you gotta make sure that you've checked all the boxes and crossed all the T's, and that this patient's alarm is because of the underlying physiology, not because you didn't consider something. Now, when does the patient get better? For example, your plateau pressure is going to start coming down. Your dynamic compliance, which is your how much it takes to deliver your breath, so it's tidal breath divided by your PIP and PEEP. Your expiratory curve starts to return to normal by itself. Your minute ventilation stabilizes. Your end tidal starts to come down. And then this is something that I like with the ventilator, like the G5, is because you have the tidal breath inspiratory and the tidal breath expiratory. So the VTI and the VTE discrepancy starts to narrow. And then your peak inspiratory pressure drops when resistance decreases. Your I/E ratio is improving. And then you'll see that your end tidal CO2 is starting to come down. And your auto average for asthma, it's 1 to 3 days. For COPD, you're looking at 3 to 7 days. And so it's a tincture of time. One of the worst things you can do is work your way into a highly agitated state because you agonize over helping your patient. And so sometimes you just have to sit back and say, okay, check, tincture of time for the steroids to start working. Airway clearance is ongoing. Bronchodilator is being dialed in. So in permissive hypercapnia, you have to have this on your protocol. Give half slowly. You use a 0.5 for the body weight. Whenever you use bicarb, change your IV to normal saline so you don't end up with metabolic alkalosis with hypochloremia. Now, people say, how do I bronchodilate? Well, guess what? It depends on where you put your nebulizer. So if you look at this cartoon, which was a trial looking at the best place to put it, this is your expiratory limb, this is your inspiratory limb, and this is your water collector. You can put it in many locations, but the optimal one is the one that's closest to the patient. Humidity, remember, if you're nebulizing something and your humidity is very high in your circuitry and you've got water pooling there, very few of the drug is going to reach your patient. So the closer it is to the patient, the more it goes into the patient. Otherwise, you'll just go into the expiratory limb and into the machine. One of the things that you could help when somebody is intubated is to use continuous nebulization for the first hour or so. That way, the RT isn't called all the time and the nurse isn't called upon to mix the medication right away. So In mild asthma, 5 milligrams, you QS to 30, and then you just let it go. In more severe asthmatic, you may want to use 4 vials. You just have to be careful about the electrolytes and the tachycardia and the tremulousness, because your patient's not going to be comfortable. Finally, if we look at the anti-inflammatory medications, I came of age wherein people were pushing a lot of steroids. You end up with critical care myopathy. And so if you keep everything under 2 mg per kg, you should technically be safe. The minute you add on paralytics, that's another can of worm. And so you have to monitor, you have to be very careful. Finally, airway clearance is very important in COPD and asthma. Mucus is very, very tricky. It plugs things. And then the minute you have a positive pressure ventilation, mucus extraction becomes active. You have to do it. The patient's not going to be able to cough things up, okay? And if you look at what we just showed you, it's very important to be able to clear the airways. So it's a relatively simple talk. I hope the major concepts are imparted. And the philosophy I always have is that I'm not here for you to enter my understanding, but to lead you to your own understanding so that you'll be a better doctor than I am. Thank you.
Bueno, muchísimas gracias al doctor Kaiser Lim, y tenemos nuestra última conferencia del Congreso, que en este caso invito nuevamente al doctor Gustavo Cortés Puentes. Esta agenda académica cierra con el cuidado integral del adulto críticamente enfermo.
Creo que el título era diferente, pero vamos a ver. Bueno, esto es una charla. Yo creo que la cantidad de anglicismos va a ser mucho mayor en esta charla que en la anterior. Entonces, paciencia. Pero es una charla de disincronía entre el paciente y el ventilador. Entonces, por favor, si están cansados, siéntense libres de ponerse de pie, estirar las piernas un poco. Vamos a hacer esto un poco interactivo. Y básicamente los objetivos es un reconocimiento de patrones específicos de sincronía y también mirar algunas estrategias de cómo podemos abordar estos problemas y asegurarnos que nuestro paciente esté mucho más cómodo con el ventilador. Me gusta empezar mucho con esta trilogía de la respiración mecánica, y es hablar del trigger, el target y el ciclado. Son parámetros específicos que básicamente inician la transición entre la expiración y la inspiración, lo cual llamamos el trigger. Y esto puede ser básicamente con un tiempo específico, como lo hacemos en pacientes que están sedados de manera profunda, por ejemplo, en modos como la presión o modos de control de presión. Pero también puede ser el envío de una respiración mecánica después de que el paciente es capaz de generar una presión o un flujo específico después de generar un esfuerzo respiratorio por sí mismo. Después tenemos el target, que es básicamente la variable que no cambia durante la fase inspiratoria de la respiración mecánica. Y finalmente tenemos el ciclo, que es ese parámetro que dictamina la transición entre la inspiración a la expiración, y esto puede ser básicamente después de haber enviado al pulmón una cantidad específica de volumen o después de haber pasado un cierto periodo de tiempo. Y también hay parámetros de ciclado de flujo, como lo vamos a ver en pacientes que están en presión soporte. Entonces, traigo esto a colación, esta separación entre los diferentes ciclos de la respiración mecánica, porque cada uno de ellos puede experimentar disincronías entre el paciente y la máquina. Entonces tenemos una distribución, una clasificación de aquellas disincronías que afectan el trigger, las disincronías que afectan el flujo y las disincronías que afectan el ciclado. Las más frecuentes que encontramos en el trigger son esfuerzos de respiración que fallan o que se pierden, esfuerzos gastados o desperdiciados. Y tenemos también el double triggering, que vamos a ver. También tenemos el auto triggering y el trigger reverso, que es bastante frecuente y que lo vamos a ver la distribución en algunos momentos. También tenemos disincronías en la fase del flujo, y estas son cuando el flujo inspiratorio es insuficiente relativo a la demanda que tiene el paciente, o cuando el flujo es excesivo relativo a la demanda del flujo. Entonces tenemos insuficiencia de flujo o un exceso de soporte, como lo vamos a ver en algunas gráficas. Y finalmente tenemos las desincronías del ciclado, en donde tenemos una transición hacia la expiración de manera prematura relativamente a la fase inspiratoria que el paciente quiere establecer, o una transición a la expiración de manera retardada, lo que quiere decir que la máquina tiene un tiempo inspiratorio muchísimo más largo que lo que el paciente desea gastar en inspiración. Entonces vamos a ver algunas de las gráficas. Y es un modo, digamos, sistemático de reconocer estas disincronías, básicamente tratando de responder a las preguntas, identificar cuál es el target que tenemos en un modo específico, y también mirar aquellas respiraciones que son iniciadas por el paciente y soportadas por la máquina, y tratar de mirar cuáles son estos parámetros que no cambian o cuáles son los parámetros que cambian durante la fase inspiratoria o expiratoria del paciente. Entonces tenemos esta pregunta, la primera. Entonces observemos la gráfica aquí. Para orientación de todo el mundo, tenemos al principio la gráfica de presión sobre tiempo. La segunda gráfica es la gráfica de flujo sobre tiempo, y la siguiente es la gráfica de volumen sobre tiempo. Entonces, por favor, ¿cuál de los siguientes disincronías, en cuál de las siguientes clasificaciones se puede clasificar esta disincronía que observan en la gráfica? A, una disincronía de trigger; B, una disincronía de flujo; C, una disincronía de ciclado; o D, sencillamente no hay disincronía. Esto es un ejemplo de ventilación asistida con ajuste neurológico y no hay disincronía en este caso. Entonces piensen un poco en la diapositiva. No estoy seguro si está funcionando esto. Ok, perfecto. Entonces vamos a mirar. Se supone que la respuesta sale en alguna parte. Bueno, no importa, vamos a seguir. Bueno, espero que todos lo hayan tenido correcto. La respuesta es B, es una desincronía de flujo. Entonces, ¿qué es lo que estamos observando acá? Lo que estamos observando es que el flujo inspiratorio es insuficiente relativo a la aumentada demanda que presenta el paciente. Esto es lo que llamamos una inanición de flujo, o un flujo insuficiente. En inglés se llama flow starvation. Y lo que vemos acá es la representación clásica de la ecuación de movimiento. Entonces, cuando pensamos en la presión total al final inspiratorio o al final de la inspiración, la presión total es la relación que existe, o la suma de la presión del ventilador con la presión que genera el paciente. Entonces, si la presión que genera el ventilador siempre es de presión positiva y el paciente está totalmente pasivo y sedado, la presión del paciente va a ser 0, ¿cierto? Entonces la presión total va a ser positiva, digamos, no sé, 15, 20 centímetros de agua. Pero si el paciente está generando un significativo esfuerzo inspiratorio, lo que quiere decir es que la presión que está generando es negativa. Entonces, una presión positiva más una presión negativa, la presión total va a disminuir. Entonces, lo que estamos viendo acá es cómo el paciente está generando un significativo esfuerzo inspiratorio durante la inspiración, porque no está recibiendo el suficiente flujo. Entonces, ¿cómo podemos ajustar esto? Bueno, sencillamente podemos darle más flujo. Si el paciente quiere más, pues aumentamos el flujo. Pero también hay otras estrategias relativamente con el perfil de envío del flujo. Entonces, si pensamos que el paciente tiene una inanición de flujo o quiere mucho más soporte, y tenemos un flujo de desaceleración durante la inspiración, el paciente quiere más flujo, y lo que la máquina está haciendo es disminuyendo el flujo durante toda la inspiración. Entonces, ese perfil de flujo va a exacerbar la disincronía. Entonces, si adoptamos un perfil de flujo cuadrado, esto va a generar un suplemento de flujo más constante y sin disminución durante la inspiración, lo cual potencialmente puede mejorar esta disincronía. Muy bien, observamos. Importante aquí, y eso es relativo a lo que el doctor Lindblom nos estaba diciendo, y es que cuando hacemos estos cambios del perfil de flujo, es importante tener en cuenta que el tiempo inspiratorio entre un flujo cuadrado o un flujo que está desacelerado es de reducción, o sea, el tiempo en inspiración es mucho menor si utilizamos un flujo cuadrado que si utilizamos un flujo de desaceleración, lo cual puede tener una influencia entre la relación entre la inspiración y la expiración y puede mejorar o empeorar el atrapamiento de aire en personas que tienen lesión obstructiva. Esto es un estudio que hicimos en la clínica Mayo, donde básicamente tratábamos de analizar cuál era el grado de incidencia y cuáles eran las disincronías más frecuentes que afectaban a los pacientes tanto con SDRA como sin SDRA. Y como podemos ver, flow starvation o inanición de flujo es uno de los más frecuentes al lado del double triggering o aquellos esfuerzos que se pierden o esfuerzos inefectivos. Entonces es muy importante tener en mente esos tres al menos para identificarlos y aprender cómo solucionar el problema. Right, pregunta número 2. Este es un paciente de 32 años con SDRA, está en el segundo día de ventilación mecánica, tiene una PAFI de 140 y básicamente la enfermera te llama y te dice que las alarmas el ventilador está alarmando y tienes que hacer una evaluación de este paciente. Cuando entras a la habitación del paciente encuentras esta gráfica, de nuevo, presión, flujo y volumen. Quiero que observen un poco la gráfica. En este ventilador específicamente encontramos que esos esfuerzos respiratorios se ven representados por este triángulo que está al inicio de cada respiración, lo que quiere decir que este paciente, por supuesto, está muy activo, tiene un drive respiratorio bastante alto y muy seguramente la tasa metabólica también está muy alta. Entonces, con eso en mente, vamos a resolver la pregunta. ¿Cuál de los siguientes maniobras es la mejor maniobra de manejo en este paciente? A, disminuir la frecuencia respiratoria. B, disminuir el tiempo inspiratorio. C, incrementar el flujo. D, disminuir el tiempo de alcance. E, incrementar la sedación. Vamos a ver. Ok, y solamente avanzo, ok. Oh, ok. Ok, muy bien. Bueno, un gran porcentaje la tuvo correcta. Ah, sigue la votación. Ok. Ok, perfecto. Muy bien. La respuesta correcta es la E. Pero yo creo que la mejor parte de esta pregunta es examinar por qué las otras respuestas son incorrectas. Entonces, lo que tenemos aquí es un ejemplo de double triggering y básicamente lo que sucede es que el esfuerzo inspiratorio del paciente, debido a la gran demanda metabólica que tiene el paciente, se extiende hacia la expiración. Entonces, cuando el ventilador hace el cambio de ciclado hacia la expiración, ese esfuerzo inspiratorio del paciente todavía está presente y lo que hace es básicamente alcanzar ese criterio nuevamente de trigger y una segunda respiración mecánica es enviada hacia el pulmón. Y lo que sucede es básicamente que la cantidad de volumen se duplica y esa combinación de volumen es supremamente deleteria para el paciente. Entonces, usualmente esto lo vemos usualmente muy temprano en el proceso de SDRA, precisamente asociado a una gran tasa metabólica y una gran cantidad de respiratory drive. Y es importante aquí, como el doctor Ocle nos estaba diciendo, recordar que realmente tenemos un rango para trabajar aquí bastante alto. O sea, el paciente quiere más volumen tidal, quiere más flujo, y si lo tenemos en 6 centímetros por kilo de volumen corriente, quizás aumentar el volumen corriente y movernos dentro del 6 a 8 puede mitigar esta disincronía. A darle más volumen al paciente, el drive respiratorio o el incentivo para respirar se va a disminuir y muchas veces incluso la oxigenación también aumenta y ese esfuerzo inspiratorio se disminuye. Sin embargo, hay que tener en cuenta que cada vez que aumentamos el volumen corriente puede existir un efecto deleterio en esos parámetros de seguridad que conocemos, como la presión plató y la presión driving de la vía aérea. Entonces, el incremento tiene que ser condicional a la permanencia de esos criterios de seguridad que tenemos que mantener. Y eso pues me trae al punto que la mayoría de las veces estos pacientes que tienen un esfuerzo inspiratorio supremamente alto lo presentan porque tienen un parénquima pulmonar supremamente afectado. Lo que quiere decir que la compliance del pulmón es bastante baja y por tanto es muy difícil realmente poder sostener esas medidas de seguridad y aumentar el volumen corriente se convierte entonces en una estrategia insegura en ese paciente. Entonces, la mayoría de las veces la respuesta correcta, incluso después de hacer un ensayo de mejorar la estrategia ventilatoria, es aumentar la sedación y muchas veces usar bloqueantes neuromusculares. Sin embargo, siempre intentar ajustar el ventilador al paciente es supremamente importante. Este es un estudio en el cual se comparó directamente aumentar la pseudoanalgesia del paciente versus hacer ajustes en el ventilador, básicamente con la premisa de aumentar el tiempo inspiratorio. Recordemos, el paciente quiere más volumen, el paciente, el esfuerzo inspiratorio o el tiempo neuronal inspiratorio es muchísimo más largo que lo que tenemos ajustado en el ventilador. Por tanto, aumentar el volumen corriente en un modo de ventilación controlado por volumen va a resultar en un aumento del tiempo inspiratorio. Entonces, ese es el juego. El juego es aumentar el tiempo inspiratorio de manera segura para mejorar o eliminar el double triggering. Entonces, si miramos el resto de las respuestas, recordemos, es un paciente ventilado en volumen control. Si disminuimos la frecuencia respiratoria, realmente esto va a aumentar el tiempo expiratorio, pero no va a tener ningún efecto en el tiempo inspiratorio. Entonces, en realidad, esto no va a mejorar la disincronía para nada, ¿cierto? La opción B, disminuir el tiempo inspiratorio. Bueno, acabamos de decir que el juego realmente es lo contrario, aumentar el tiempo inspiratorio. Entonces, si lo disminuimos, pues esto se va a empeorar. C, si aumentamos el flujo en volumen control, en control de volumen, si el flujo se aumenta, pensemos en el volumen como una marca de velocidad. Si tenemos un volumen corriente de 400, si tenemos un peak flow de, digamos, 60 o 50, si yo lo aumento a 70 u 80, el tiempo inspiratorio se va a disminuir. Entre más rápido envíe al pulmón ese volumen corriente, el mismo volumen corriente, el tiempo inspiratorio se va a disminuir. Entonces, aumentar el flujo no va a ser nada más que aumentar la disincronía. Y finalmente, el rise time, como saben, es ese tiempo que se gasta entre la expiración y alcanzar ese peak flow. Entonces, si lo disminuimos, es decir, si alcanzamos el peak flow muchísimo más rápido, también voy a disminuir el tiempo inspiratorio. Entonces, no solamente es lo más lógico aumentar la sedación, y es muy seguramente lo que hacemos más rutinariamente en nuestra práctica clínica, pero también el resto de estrategias lo único que hacen es empeorar la disincronía. Muy bien, tercera pregunta. Quiero que observemos esta gráfica, de nuevo, presión, flujo y volumen. Y quiero que pensemos en qué categoría clasificaríamos esta disincronía. A, una disincronía de trigger. B, una disincronía de flujo o ambas. Pensemos un poco. Ok, votes are still. Aún están votando. Creo que es como presión de pares aquí. Qué bien, qué bien. 43%. Ok, muy bien, perfecto. Ok, la mayoría la tuvo correcta. Esto es una desincronía de trigger. Lo que observamos aquí, como podemos ver de nuevo en este específico modo ventilatorio, este paciente está muy activo, básicamente haciendo trigger de cada esfuerzo respiratorio y la máquina está soportando cada respiración mecánica. Sin embargo, vemos aquí que hay una distorsión en la parte expiratoria y vemos que a pesar de esta distorsión del flujo, no existe una respuesta adecuada del ventilador. Entonces, lo que vemos aquí es que el paciente realmente está respirando, tiene una frecuencia respiratoria el doble de lo que hemos representado en la máquina. Eso es básicamente como un 2-1 atrial flutter que vemos en cardiología. Entonces, básicamente el paciente es incapaz de hacer que la máquina dispare una respiración mecánica cada vez que lo desea, solamente una que otra respiración. Entonces, ahí lo vemos representado. Y lo que tenemos que hacer es básicamente ayudar que ese trigger de la respiración mecánica sea muchísimo más fácil. Y esto depende de qué es lo que está causando esa, digamos, esa falta de sensibilidad de la máquina al esfuerzo respiratorio del paciente. Eso se puede ver básicamente porque a veces la configuración de nuestro ventilador está inapropiado y tenemos un trigger de sensibilidad muy alto, que estamos esperando que el paciente genere una presión muy negativa o un flujo muy alto y podemos ajustar eso para hacerlo más fácil, para que la máquina reconozca el esfuerzo respiratorio más fácil en el paciente. Sin embargo, como el doctor Kaiser Lim estaba revisando anteriormente, muchas veces la presencia de auto-PEEP puede generar un incremento en esa demanda de llegar a ese parámetro para hacer que el ventilador soporte la ventilación mecánica, y esto es lo que llamamos auto-PEEP. Lo que quiere decir es que el paciente no solamente tiene que llegar a ese límite en donde el ventilador va a dar el soporte para la siguiente respiración, sino que tiene que pasar por encima de ese air trapping o de ese atrapamiento de aire que está generando presión y después de eso generar ese parámetro de trigger de la ventilación mecánica. Entonces, la presencia de auto-PEEP básicamente aumenta la cantidad de trabajo que el paciente tiene que hacer. Entonces, si el problema es solamente de ajuste de los parámetros del ventilador, fácil. Si el problema es de atrapamiento de aire, tenemos que resolverlo. Usualmente lo que podemos hacer es usar PEEP extrínseco, que lo que es básicamente es el PEEP que tenemos en el ventilador, básicamente para hacer ese ajuste y llevar al mismo nivel. Y el doctor Lim hizo una analogía bastante interesante que es aumentar el nivel del agua para ayudar a que el paciente mire al otro lado del muro. Yo lo miro como que si tuviéramos un bote en esta parte, lo que queremos hacer, yo comparo tener una respiración mecánica exitosa con poder pasar con el bote hacia el otro lado. Entonces, para poder pasar con el bote hacia el otro lado, necesito tener una cantidad de agua un poco encima del muro para que mi bote no se quede estancado allí. Y lo que hago es aumentar el PEEP, aumentar el nivel de agua para efectivamente poder pasar el bote al otro lado. Entonces, esa es la teoría de cómo usar el PEEP para hacer un ataque selectivo a la cantidad de air trapping que el paciente tiene. Y por supuesto, también se soluciona con el tratamiento de la enfermedad obstructiva del paciente. Y esto me lleva a la disincronía más filosófica que podemos ver. Entonces, aquí los quiero orientar un poco. Aquí las gráficas cambian un poco. En la parte superior tenemos la gráfica de flujo. En la parte media tenemos la gráfica de presión. Y en la parte inferior tenemos una gráfica de la presión esofágica. Lo que está pasando aquí básicamente es que, como pueden ver, cada respiración es realmente pasiva. Quiere decir que el paciente no tiene esfuerzo respiratorio. Y vamos a observar, por ejemplo, este esfuerzo respiratorio está muy pasivo. La máquina envía el volumen corriente e inmediatamente después de que esa respiración mecánica se ha enviado, hay un esfuerzo inspiratorio del paciente. Y pasa lo mismo en todas estas respiraciones, pero sin embargo hay una de ellas en la cual ese esfuerzo inspiratorio está muy cerca de ese parámetro ventilatorio en el cual la máquina envía otra respiración y se genera un parámetro muy, muy parecido a double triggering. Pero de nuevo, este paciente está totalmente pasivo. Entonces, si pensamos en esto, ¿cómo puedo yo clasificar esta disincronía? ¿Como una disincronía de trigger, como una disincronía de flujo o como una disincronía de ciclado? Vamos a empezar la votación. Ok, very good. Muy bien. Esta disincronía se puede clasificar como una disincronía de trigger. Entonces, de nuevo, lo que está pasando aquí es algo que se llama reverse o trigger reverso. Entonces, usualmente pensamos que el paciente genera un esfuerzo inspiratorio que alcanza ese parámetro de trigger que puede ser de presión o flujo y después la máquina hace el soporte con presión y volumen para generar una ventilación mecánica. En este caso es el contrario, es reverso. Lo que parece es que el paciente está sedado y pasivo, la máquina envía una ventilación mecánica e inmediatamente después de eso parece como si la máquina hiciera el trigger del paciente. Entonces es un esfuerzo inspiratorio del paciente después de que la máquina ha enviado un esfuerzo mecánico pasivo. Y esto sucede básicamente, una teoría es que existe un ritmo intrínseco en los pacientes severamente enfermos que está totalmente en disincronía con lo que estamos haciendo con el ventilador. Entonces, ¿cómo se diferencia? Porque esto se ve muy parecido a double triggering, ¿no les parece? Entonces, ¿cómo se diferencia el double triggering de un reverse triggering? El número uno es que usualmente double triggering pasa en un paciente que es supremamente activo. Es el paciente que puedes ver el esfuerzo inspiratorio en la musculatura abdominal, en la musculatura torácica. Este pasa en un paciente que está supremamente pasivo, un paciente que está sedado, un paciente que puede o no estar con algún grado de bloqueo neuromuscular, porque puede haber taquifilaxis y los pacientes pueden tener 2 o 3 de 4 en el Trenos 4 de assessment de bloqueo neuromuscular. Y lo que sucede es básicamente que una teoría es que los mecanorreceptores de la distensión hacen que ese diafragma se contraiga y dependiendo del grado de contracción genera presión o flujo que básicamente disparan otra ventilación mecánica y dependiendo de eso pues puede haber acumulación de volumen corriente y el paciente puede recibir el doble del volumen corriente. Como sucede muy frecuentemente en pacientes que están ya sedados, muy frecuentemente la única solución es aumentar la sedación o básicamente hacer el bloqueo neuromuscular del paciente. Pero también se está intentando clasificar esta disincronía como una disincronía de ritmo. Uno puede ver reverse triggering en atletas de alto rendimiento o incluso en algunas especies animales que corren muy rápido, como leopardos, etcétera. Entonces, puede existir una relación entre la alta actividad metabólica y la función cerebral y lo que uno puede hacer es tratar de aumentar la respiración del paciente, tratando de mejorar la ritmicidad o de ajustar la ventilación mecánica al ritmo intrínseco neurológico del paciente. Pero muy frecuentemente eso no funciona y la maniobra adecuada es instaurar el bloqueo neuromuscular. Ok, la siguiente pregunta. ¿Cuál de las siguientes es el mejor manejo para este paciente que está ventilado con ventilación de presión de soporte? Entonces quiero que pongamos atención de nuevo. Esto es una gráfica de presión sobre tiempo y este es el flujo. Y las opciones están en la pantalla. Disminuir la sensibilidad de disparo expiratorio, quiere decir disminuir el parámetro, la presión o el flujo que el paciente tiene que generar para que la expiración se haga la transición a la expiración, o aumentarla o disminuir el tiempo de alcance o aumentar el PEEP. Ok, bueno, la respuesta correcta es disminuir la sensibilidad de trigger expiratorio. Entonces, este paciente está ventilado con ventilación de soporte. La gran diferencia de ventilación de soporte en cuanto al ciclado, quiere decir la transición entre la inspiración y la expiración, es un parámetro de decaída, se llama decaída del peak flujo. Y cómo funciona es de la siguiente manera. Básicamente, lo que podemos programar en presión de soporte es el porcentaje al cual el paciente va a hacer la transición de inspiración a expiración. Entonces, yo puedo hacer ese ajuste para que una vez el paciente, la decaída del flujo alcance el 50% del el pico de flujo, el paciente va a expiración. O lo puedo hacer hasta que el paciente alcance el 75%, o puedo disminuirlo aún más al 30 o el 25%. Entonces aquí la semántica es que entre más alto el porcentaje, más corto será el tiempo inspiratorio. Entre más bajo sea el porcentaje, más largo será el tiempo inspiratorio. Entonces, si el paciente está yéndose a expiración de manera prematura, lo que tengo que hacer es básicamente hacer el tiempo inspiratorio más corto. O sea, permitir que el paciente vaya a expiración de una manera más rápida. Y eso lo hago disminuyendo la sensibilidad de expiración del paciente. Entonces, esa es la respuesta correcta. Esto lo puedo hacer también en volumen corriente, pero recordemos que en volumen corriente el tiempo inspiratorio depende del pico flujo y del tamaño del volumen corriente. Y por supuesto, si estamos en presión controlada, yo controlo el tiempo inspiratorio, entonces tengo que ajustar el tiempo inspiratorio del paciente en el ventilador. Eso también puede suceder al contrario. Lo que quiere decir es que estoy manteniendo la inspiración mucho más de lo que el paciente quiere. Entonces, esto es un ciclado demorado o tardío. Y lo que tengo que hacer, y de nuevo aquí la ecuación de movimiento, como pueden ver, a esa pequeña espiga al final de la inspiración, y es cuando el paciente está peleando con la inspiración del paciente. Entonces una presión positiva más una presión positiva aumenta la presión total y podemos ver esa espiga al final. Y lo que tenemos que hacer es básicamente incrementar el sistema del ciclado. Entonces lo que hago es aumentar el número de porcentaje, lo cual va a disminuir el tiempo inspiratorio del paciente y mejorar la disincronía. Bueno, muy bien, esta es la última. Vamos a ver, ¿cómo puedo clasificar esta disincronía? De nuevo, los parámetros son iguales: presión, flujo y volumen. Ok, muy bien. Excelente, muy bien. La respuesta correcta es autociclado. El autociclado es una disincronía que yo creo que era mucho más frecuente en el pasado cuando usábamos más tubos torácicos de alto calibre. Ahorita con el advenimiento de pigtail catheters y todo esto es muchas veces mucho menos frecuente. Y básicamente estamos alcanzando ese parámetro de trigger, no por el esfuerzo del paciente, sino por cambios en la presión o el flujo de la vía aérea debido a una cuestión totalmente externa al paciente. Y por supuesto pueden haber muchísimas condiciones clínicas que pueden generar esto. Muchas veces en pacientes que son delgados, con un corazón muy grande, y si la sensibilidad está, digamos, bastante pequeña, podemos sensar la máquina puede sentir esas palpitaciones y ese cambio de flujo y presión, y muchas veces vemos que el ciclado hace perfecta concordancia con la frecuencia cardíaca del paciente. Esa es una opción. Muchas veces la humidificación del circuito es bastante elevada y hay acumulación de agua en el circuito. y ese vaivén del agua en el circuito puede generar cambios de flujo y presión que son interpretados por la máquina como esfuerzos respiratorios, y la máquina básicamente hace el ciclado bastante frecuente de esto. Y en el pasado, o pues también en el presente, especialmente si hay fístulas troqueobronquiales, o tenemos un tubo de alto calibre que está conectado a una succión, esa succión puede transmitirse a la vía aérea central y generar ese ciclado frecuente. Muy bien, eso es como la mejor charla para tener la mejor del almuerzo, antes del almuerzo. Pero es un abrebocas de la mayoría y las más frecuentes de las disincronías que se pueden ver en el paciente. Yo pienso que entre double triggering, wasted efforts o esfuerzos inefectivos y flujo inapropiado o flow starvation son los más frecuentes y son los que quizás debemos ponernos más prácticos en resolver en nuestras UCIs. Entonces, muchísimas gracias y de nuevo ha sido un placer.
Bueno, muchísimas gracias a los valientes que resistieron hasta el final. Los que nos están viendo virtualmente y los que nos van a ver posteriormente, quiero decirles solamente que en estos 3 días al inicio de esta conferencia, nos propusimos unos objetivos. Después de esos 3 días, podemos decir que esos objetivos están cumplidos, que tuvimos unas excelentes redes de trabajo, unos excelentes intercambios de experiencias, ¿sí? Que seguimos teniendo una puerta de entrada para continuar con estas relaciones y con estos proyectos que hemos alcanzado el día de hoy. Gracias a todos por venir. Gracias a nuestros amigos de la Clínica Mayo. Realmente estamos muy agradecidos y les solicito por favor un aplauso para ellos. Gracias también a todos nuestros conferencistas, amigos que hicieron parte de este proyecto y que aceptaron la invitación. Realmente muchas gracias. Y por supuesto a todos los asistentes. Durante estos 3 días, ya me acaban de dar los datos totales, tuvimos una asistencia presencial de 362 personas en la sección de adultos, 203 personas en la sección de neonatos, 188 asistentes a los escenarios clínicos. Se expusieron 27 póster en la competencia de investigación y virtualmente durante el día 1 nos vieron 780 personas o asistieron 700 personas y durante el día 2 720. Durante el día de hoy esas redes estaban que ardían. Todavía no tenemos el dato, todavía seguimos transmitiendo. Y además de eso, si uno compara todos estos datos, pues alcanzamos la totalidad de aproximadamente 1.300 personas con con nuestra conferencia. Entonces, muchísimas gracias a los asistentes y a los valientes que quedan hoy de pie todavía aún más. Muchas gracias. Y todo esto fue posible gracias al excelente equipo organizador que tenemos, al excelente equipo de los Codos Medical Center, al excelente equipo de la universidad. Doctor Hugo, muchísimas gracias por la confianza, muchísimas gracias por la confianza de la Universidad del Bosque, y a todos, muchísimas gracias.
Yo quiero darle un reconocimiento especial al doctor Luis Arcadio, ya que con su esfuerzo y dedicación logramos hacer este congreso. Realmente, Lucho, mi admiración y muchas gracias por este congreso que estuvo muy interesante.
Bueno, pues para mí de nuevo es un placer estar acá. Yo creo que hablo a nombre de todos los acompañantes y mis colegas de la Clínica Mayo. Para nosotros siempre es un honor educar no solamente en ventilación mecánica, sino en cuidado crítico en general. Y yo creo que nos llevamos el mejor de los recuerdos y es realmente supremamente enriquecedor y contagioso y estimulador ver ese apetito académico que todos han mostrado, las sesiones de profesor asistente en las cuales pudimos interactuar más cercanamente con los diferentes fellows y residentes, fue bastante estimulante y esperamos seguir nuestra colaboración. Y pues nada, yo realmente darle las gracias a los codirectores de la conferencia por todo el trabajo y la organización y muchísimas gracias a todos por hacer parte de este evento. Muchas gracias.
Bueno, que tengan un excelente almuerzo y nos veremos próximamente.